हेलो। एक मिनट रुको। एक मिनट होल्ड करो। हेलो। आप उससे कनेक्ट आओ ना, मेरे उसमें अभी कनेक्टेड नहीं हो आप। हाँ, अभी आपका ये दिखा नहीं रहा है अभी। नहीं, मेरे इसमें आप कनेक्टेड नहीं हुए हो अभी। ए हाँ, हाँ, अभी कोई स्टूडेंट है नहीं अभी। एक मैं खुद ही एकेडमी हमारा ही वाला ही दिखा रहा है, अभी आपका दिखा नहीं रहा है। हाँ जी, वो तो 5 बजे तक चलेगा आज एकेडमी इसका, टू वालों का तो आपका कनेक्ट क्यों नहीं हो रहा अभी? मेरे इसमें हो ही नहीं रहा है। हाँ, ये हो सकता है क्योंकि मैं हमारा तो ऑलरेडी। मैं तो जैसे ही क्लास खत्म होता हूँ मैं निकल लेता हूँ। हाँ जी। ठीक। ठीक। हेलो। ना सामने तो ना हो भाई, मैंने उससे बोल ली है अभी तो। हाँ, 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 हाँ। ओल्ड मूव का होगी। अरे अब तो दिल्ली की डिफेंस में प्लास्टिक में ही आवे। कैंटीन में उसकी आओ प्लास्टिक की। सांझ का तू बता के प्रोग्राम है, मना की बेरा के प्रोग्राम है। बना लियो भाई। क्या है भाई? दो हो त्री दो। एक ले आऊंगा बस। तो यहाँ ना है ना भाई वो। और तो भाई यहाँ ना है, यहाँ ना है वो। अरे तो यहाँ ना है भाई। देख लूंगा फिर मैं। ठीक है। कि मैं कर लियो तू भाई। देख लियो। हाँ, वही कर लियो, कुछ भी कर लियो तेरी इच्छा। हेलो।
हटो। इसलिए भक्का है, मैंने कहा आज मैं करूँगा। करा दी तुमने?
अभी तो 2 बजे आएंगे।
हैं?
2 बजे आवेगी।
कट कर दो इसे।
किसको होगा भी कुछ मत करे।
अभी हो ही नहीं है क्या? चलो
अभी तो बंद है। अभी तो आने वाली होगी।
हटो, तुम मेरे को बैठने दो, तुम तो बैठे रहते हो।
बस तो ले कर दिया सबका
रुक
काम।
जाओ, मेरे को अभी थोड़ी सी कंफ्यूज है ना, जब मैं एकदम क्लियर हो जाऊंगा ना एकदम
जैसे रेडी है अभी हो, कुछ ना करना बस सब।
इसीलिए तो मैं कर रहा हूँ, इसे सबको हटा रहा हूँ, मैं वापस कर रहा हूँ मैं।
अरे फिर क्यों करा वो 45 पे कहती है उनकी, फोन आया था उसका।
हाँ तो दोबारा कर दो, इसे 2 मिनट तो लगेगी।
कर ले भाई।
चलो ना, कट कर दो सीधा यहाँ से।
हाँ
ये लो, एंड मीटिंग फॉर ऑल है। ठीक है, यस, ये हो गया जी। ठीक है, वापस करना ना।
अभी ये सब ऑन है, ये तो ऑन है अभी, बस ये ऑन है अभी तो।
ये ऑन है,
सब कुछ ऑन है, बस गो टू मीटिंग वाला ही करना
भाई
बस।
यही तो चक्कर है, इसी का ही तो फंडा है, यहाँ से जो वो चलती है स्टॉप।
वो सब ऑन है, वो सब ऑन है।
नहीं, मेरे को करना है ना, पहले ये करना, फिर गूगल करना, फिर गो टू मीटिंग करना है ना।
अब तेना बस गो टू मीटिंग करके और यो करना बस।
स्टार्ट।
कुछ ना
अच्छा,
करना।
फर्स्ट टाइम बेस, ये लो कर दिया। आ जाओ, रुको, क्रिएट मीटिंग, ये आ गया। फिर अब इस पे पहले तो ये बंद
है
करो
ना, उसने बंद क्यों करा? अभी हम बंद ही रहने चाहिए कोई।
हाँ, ओके, आई एम रेडी है। ये जी आ गया स्क्रीन।
बस स्क्रीन शेयर करके।
स्क्रीन शेयर, ठीक है। अब मिनिमाइज, मिनिमाइज कर दिया। अब ओके, ये तो आ रहा है
बस आ रहा है और की।
बस। कुछ नहीं करना। अब इसको एक कर दूं।
इसको
अब आगे जो भी खोलेंगे वो दिखेगा सबको।
सब दिखेगा।
चलो यार, हमारे तो यार हाथ पैर बिल्कुल खत्म हो गए। क्या बात हो गई?
पता नहीं कितनी बार फोन कर दिया, 200 बार फोन कर दिया सुबह।
ये मैडम ने, और अब आई नहीं।
पता नहीं किस किस के वजह से मतलब उसको 200 बार।
हैंचल बुढ़ापे में तो ना दुखूंगी ये हड्डियाँ जब बजा दें। घुटना तो हो गया खराब मेरा भाई। कल जाऊंगा मैं दिखाने स्पोर्ट्स इंजरी, सुबह ही सुबह पहुंच जाऊंगा 9 बजे वहाँ। घुटने में बहुत ज़्यादा दिक्कत कर रहा है ये। मैं छोटी मोटी दर्द वर्द की तो चीज़ें मैं खुद करता ही ना हूँ।
मैं तो कह दूंगा डॉक्टर आदि को कुछ है ही नहीं करते कहीं कि भाई उतना तो उनको नहीं बता रहा उसको इसको दोनों। हाँ हमें सब आइडिया में क्या
वो दोनों इसको
हाँ मुझे आइडिया में क्या कर सकता हूँ कुछ मैं थोड़ी बोलूँगा उनको।
और क्या
मुझे बता रहा है एक तो मैंने बता दिया है वो हो गया है अब वो आइडिया है वो भाग जाता मुझसे ये करूँ
किसके
गाड़ी को
किसके लिए
तिवारी गाड़ी
क्या भाग जाता है?
क्लास ही ना किए गए बैठ के
हाँ वो तो बोला कई बार देखा वो साथ में से बोला।
बता दी तो उस कहेंगे वो ये नहीं करेंगे सीखा हमें मगर उनको होगा तो आएंगे सही। तो ये हो गया क्या दबे का पाल लिया।
भाई घड़ी किसकी है भैया?
जिसकी वे थोड़ी ध्यान नहीं।
स्वच्छ लोकल नहीं, लोकल तो नहीं, स्वच्छ कंपनी है भाई बढ़िया।
वो किसी का समय को कोई वीडियो करे अच्छा से होगा।
हैं?
किसी का समय को तो क्यों करे अच्छा से होगा।
और बताओ भाई, कोल्ड ड्रिंक है? कोल्ड ड्रिंक
तो ये क्यों लो
है?
कई दिन की है।
क्या दिन की है?
अबे 15 दिन तो
15 दिन। वैसे तो ना खराब तो ना।
मुझे नहीं आया तो सिक्योरिटी वाले रिटायर हुआ है ना
तो मैं पीती नहीं
सही है नहीं तो पीजिए
पीने के टेस्ट तो देता चला।
सिक्योरिटी वाला दे दी एक कोल्ड ड्रिंक
तुम्हें
और
अच्छा है।
वेगन पे
तो नोट लगा ले हैं। आप बंद कर दे मैं रोज ऐसा पी रहा
ना मेरा ना नो उसके सामने भी कभी ना देखो
नहीं पहले नहीं पता तुम्हें पता नहीं डॉक्टर
वही सो मतलब चाहिए अभी खुद ही ले आया अपने आप
उन्हें पता है ना मनमोहन भुट्टी देता है। लगा करूँ
यूट्यूब पे भी डाली
आवाज स्पीकर स्पीकर बंद है।
यूट्यूब पे
स्पीकर बंद है लेकिन आवाज जा रही है। तो मेरे में आवाज क्यों नहीं विदाउट परमिशन? हाँ हेलो 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 हेलो
हेलो।
रिकॉर्डिंग तो ही नहीं।
तो मेरे को तुमने एक बार बताया बस करा दो जी। बोलो सर हम तो ना तो भर के पैदल जाने उनके लिए कुछ नहीं। तो तुमने तो स्टॉक में रखो मैंने फिर इसके में मोबाइल लिया छोटे से मोबाइल लिया था।
मिक्स करो ना इसको उसको
इसको
ये वाले और उसको दूसरा
सेम ही सारे एक ही है।
एक ही है। तो इसकी बॉटल में तो अलग ही लगा। इसमें खपत ज़्यादा है इसकी, क्या बोलते हैं सैनिटाइजर की खपत ज़्यादा है। वो जो है ना उसका वो दे और ये यूज का मतलब फैला के दे सकता है हवा को। अब चिपकादर की तो वो ना चिपकादर की तो दिक्कत ना और जब 3-4 दिन बाद वाली गिरी पड़ी और जब उसे पता कौन सा खुला था ये वाला दिन पता ये वाला था शायद मौसम तो कैसे निकल लोग मेरे को अभी क्या नहीं लाइट में होती हूँ वो नहीं है वो मेरे को इसके ऑनर छोड़ा हुआ था कटिंग ना परमिशन नहीं है ना मेरे को दूसरा परमिशन तो ऑडियो पहले का इसको मतलब को वहाँ से रिसीवर का कुछ कर रखा है ना डिलीवरी नहीं है हाँ तभी तो मैंने वही तो कर रहा था परमिशन परमिशन भी कर रहा है जैसे ये ना दिस टू इंटरनेट ऑडियो विदाउट हिज परमिशन गो टू मीटिंग कॉल सपोर्ट ऑडियो तो वहीं से दिक्कत है वहीं से सपोर्ट
अभी रहने दे तू रहने दे वो खत्म
रहने दो
अभी रहने दे
कहीं पता चल रहा कुछ और करने जाए कुछ और हो जाए
ये काम
कौन सा पावर पॉइंट
No, no.
एम्स कौन सा
16.
कॉपी कर दो ये पता खोल रहा है फोल्डर
Copy, copy. No, 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 it's okay. Keep it. They'll play directly, na videos.
ये वाला है
हाँ
पेट्रोल
बस
ये वाला
हाँ
कॉपी कर दो
नहीं पूरा
पूरा कर दो पूरा
हाँ,
फोल्डर
पूरा
कॉपी
फोल्डर हाँ बट वीडियोस का कुछ नहीं होगा ना
अच्छा
इसलिए
पूरा फोल्डर ही कॉपी है
और देना पूरा फोल्डर मांगना ये वाला मैम ठीक है
okay
This
can
one,
you
this
just
one.
check if videos are playing
हाँ
videos
वीडियो चेक करने के लिए कह रहे हैं
हाँ करेंगे।
1 मिनट फोल्डर कॉपी हो जाए तो उसके बाद
हाँ
खोलते
हाँ
हैं।
हाँ। टाइम कितना हो रहा है?
टाइम अभी 5 मिनट है, 3 मिनट है, हो गया पूरा।
एक ही मिनट?
नहीं नहीं अब नहीं है, 1 मिनट एक्स्ट्रा हो गया बल्कि। हाँ 2 नहीं 2 बज गए पूरे करेक्ट। बैठ जाओ मैम, अजय।
अच्छा 80 स्टूडेंट्स ओनली?
अभी अभी तो हो जाएंगे 80 है, फिर 150 40 पहुँचेंगे।
ये तो हम लोग
टक
हैं।
टक 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 आ जाएंगे ना?
आ जाएंगे। हो गया मैम, ओपन करूँ?
क्या?
ओपन करूँ? ये वाला है?
हाँ हाँ। स्क्रीन शेयर हो रहा है? नहीं ना?
हाँ हो रहा होगा, हो रहा है, 1 मिनट
वो करवाए तो
चेक कर लो।
नहीं हो रहा है।
हो रहा है ना? ये हो रहा है, ये हो रहा है।
अभी मत कीजिए स्क्रीन शेयर।
ये करो ना।
ओके। अच्छा आपके फ़ोन पे। और ये स्टूडेंट पूछ रहे थे ये लाइव टेलीकास्ट हो रहा है?
हाँ
फिर वो कह रहे थे कल का वीडियोस वो
Start recording?
एक्सेस नहीं पा रहे कर पा रहे यूट्यूब में।
कर दो रिकॉर्डिंग।
हाँ हाँ
नहीं ये तो हमारा रिकॉर्ड कर लिया।
हाँ।
This conference will now be recorded.
ओपन। क्या करो, क्या करो?
आवाज़ बोल देगा।
कर दो। क्या बोल रहे हो?
आवाज़
हाँ ओपन होगा।
स्लाइड ओपन करके देखेंगे।
आता रहेगा, आता रहेगा। अगर आपको करना है और म्यूट कर सकते हो।
वो है ऑलरेडी।
ऑलरेडी है तो ये आवाज़ आता रहेगा।
तो मुझे कुछ बस स्लाइड्स स्क्रॉल करना है।
हाँ बस।
और ये वीडियोस अलग अलग फोल्डर्स में खोल करके रख सकते हैं?
हाँ वो मिनिमाइज कर देना, वीडियो पॉज कर
अभी अभी 1 सेकंड स्क्रीन शेयर मत करना।
ऐसे मैं भी हमने हमारे पास,
अच्छा
हमारे पास भी है ही है।
ओके।
नया
एक
सॉफ्टवेयर
बार
है ना।
ओके एक बार स्क्रीन शेयरिंग स्टॉप कर सकते हैं? और मुझे पॉइंटर चाहिए।
ये ना
पॉइंटर
ये चल
नहीं।
दिखेगा सबको।
रेड कलर चाहिए।
नहीं है,
पता है
होता है तो मैं पूछ लेता हूँ।
हम जब गो टू मीटिंग यूज़ करते थे वो सब आते थे।
ठीक है, स्क्रीन शेयर नहीं हो रही है ना?
ओके ओके फोल्डर्स यहाँ हैं। ओके स्क्रीन शेयर नहीं हो रहा है ना?
नहीं हो रहा है।
मिनिमाइज कैसे करते हैं?
शेयर हो इसका।
Good afternoon, everyone.
Good afternoon, ma'am.
Okay, shall we start?
Good afternoon, ma'am.
Thank you so much. I'm Dr. Harisha, newly joined assistant professor in the Department of Anatomy here. Okay. So far, we have done in the first class of anatomy to study the whole body. There are different ways or different methods, right? So that are like the sub branches of anatomy. We have microanatomy, macroanatomy, which is nothing but gross anatomy. Then we have embryology. Okay, in gross anatomy, you can either study it in two ways. The system wise, divide the body as per different systems like musculoskeletal system, circulatory system, lymphatic system, nervous system, etc. Or we can even study in as regional anatomy. Okay, regional anatomy, we are dividing the body into regions. Okay, so the first class of the gross lecture today will be about the pectoral region. Okay, if you see, the pectoral region falls under the category of the shoulder. So the upper limbs, we usually start gross anatomy with the upper limbs, then we proceed over to the thorax, then abdomen, lower limb, and then we do head and neck last. Okay, so now we are going to start upper limb. So dividing the upper limb as per regions, we can divide the upper limb into 4 regions: the region of the shoulder, the region of the arm, the region of the forearm, and the region of the hand. I'm so sorry I left this not labeled. Okay, in the region of the shoulder, we study all the muscles and structures that somehow directly or indirectly help in the movements of the shoulder. Okay, so the shoulder region can be divided into the shoulder joint, which is the main, to allow mobility. Then the muscles which are attaching the appendix, that is the appendicular skeleton, the upper limb, to the trunk or the axial skeleton. Okay, these muscles lie anterior to the shoulder joint as well as behind or posterior. Okay, the muscles that attach anteriorly and bring about movement at the shoulder joint, these muscles and structures fall into the region of the pectoral region. The muscles falling behind usually attach to the scapula, which is the shoulder blade that lies behind on the posterior thoracic wall. That region is the scapular region. Okay, the other region of the shoulder is the region of the axilla. Okay, when you slightly abduct or move your hand away, the region that lies between the arm and the trunk, this region is known as the axilla. This axilla is a very important passage for structures, namely neurovascular structures that have to enter from the thorax or from the center into the upper limb, or structures that have to from the upper limb enter back into the thorax or towards the axial skeleton. Okay, so that's why the axilla is a very important region, and we will be doing gross anatomy as per these regions. So starting with the anterior aspect of the shoulder region, which is the pectoral region. The rest, in each of these regions we have the skeletal element, which is nothing but the bones and the ligaments attached. So in the pectoral region, the bones that we come across are also known as the pectoral girdle. The pectoral girdle is formed by the scapula, which is posteromedially and slightly laterally placed in the axial skeleton, and more anteriorly the bone that is lying horizontal is the clavicle. So the scapula and the clavicle articulate at the joint here laterally, and also with the axial skeleton bone, that is the sternum. The sternum bone, also known as the, what is the common name for the sternum? Breastbone. Okay, the breastbone, correct. So these two structures, the clavicle, these two bones, sorry, the clavicle and the scapula together form the pectoral girdle or the shoulder girdle. Okay. Similarly, in the lower limb, the counterpart is the pelvic girdle. The pelvic girdle, which is formed by the two hip bones on either sides, which attach or articulate anteriorly, and posteriorly the two hip bones articulate with the sacrum. Okay, the sacrum of the axial skeleton of the vertebral column. And what is the importance of these pectoral girdle bones? Through evolution, man from the quadrupedal apes, our ancestors, man has evolved into a highly intelligent and self-sustained organism, or the human being, and he has come to the erect posture, the bipedal posture. Okay. So he doesn't, unlike the lower animals, he is not using his upper limbs for locomotion, but locomotion in the sense I mean walking, okay, movement, but he is using it for more precise functions of grasp and other fine motor activities, and also for weight bearing. Okay. So for this reason, the arms cannot lie very close to the axial skeleton. That would restrict lot of movement. Okay. For that reason, the pectoral girdle is so articulated with the development of the clavicle. The clavicle helps with the scapula, the upper limb skeleton, to hang freely attached to the axial skeleton, but also gives a wide range of movement. Okay. So that is the importance of the pectoral girdle as evolution. And in this regard, the first bone of the pectoral region will be the clavicle. The scapula will be dealt in the scapular region. Okay. So this will be your first osteology lecture cum demonstration on the clavicle. Okay. So the first bone that you study in anatomy is the clavicle. The clavicle is also called the collarbone. Yes. So we've studied, you have a little idea about the general anatomy by the locomotory lectures. So first you pick up a bone, you have to see what type of a bone is it. So you have to classify the bone. So what do you think the type of bone the clavicle will fall into, the category? Any answers? Compared to the scapula, would you say the clavicle is a flat bone?
Ma'am, it is a long bone.
Excellent. Yeah. Why do you think it's long? Because its length is relatively more than its breadth, unlike the scapula.
Breath.
Yes?
Yes.
Okay. So like all long bones, like all long bones, because this is a typical long bone. This is the, can anybody identify this bone here on the pointer?
Humerus.
Very good. So the humerus is a typical example of the long bone, and the humerus is the bone of which region?
The upper arm.
Arm. Okay, arm. The other word for arm is brachium. Okay. Yeah, so it's the brachial bone, but it's the brachium, arm of the bone of the arm, that is the humerus. So looking at this humerus, you see it has a long shaft, okay, and two ends. Similarly, the clavicle has a shaft and two ends. Okay, so we classify the clavicle as a long bone. Okay, we will come to a different conclusion by the end of this class. And what is the location of this bone in rest to the appendix, appendicular and the axial skeleton? Unlike all other long bones, you see, you can appreciate that the clavicle is lying. Any answers?
Horizontally.
Excellent.
Answers.
Yes, yes, yes. So unlike other long bones which are vertical in the appendicular skeleton, the clavicle is a bone of the appendicular skeleton, like part of the pectoral girdle, but it lies horizontally. All of you can appreciate it. So it lies horizontally. So one end attaches with the axial skeleton, that would be the medial end, and the other end would be the lateral end. Okay, so that will be the presenting parts of the bone. It has a shaft, it has a medial end, and it has a lateral end. The medial end articulates with the axial skeleton, that is the sternum, and the lateral end articulates with the pectoral girdle bone, that is the scapula. Okay, and we will see the parts of the scapula. In between, if you want, you can guys just change your screen. Okay, I can show you the bone. Can you see the bone?
No, Dr. Alisha, the video is, you are trying to play the video?
No ma'am, not the video. On my screen, I am just holding the bone.
No. Yes, ma'am, we can see.
Okay.
Yes, ma'am.
We can
So
see.
we can see it.
You can see it, right? Yeah, I'll ask you when I am talking about the PPT, I'll ask you to change your screens. Is that okay? Okay. So if you see, the clavicle has the intermediate shaft, a medial end and a lateral end. And how do you differentiate between these medial and lateral ends? If you see, the medial end is more enlarged, okay, roughly quadrilateral, whereas the lateral end is more flattened. Can you see? It's more flattened, okay. Below this lateral end, you can see this part of the bone, this beak-like process that is pointed anteriorly. This is the coracoid process of the scapula. The scapula, you can see, appreciate that it has 3 projections. Okay, so these are the processes. Processes are nothing but things, bony projections that are coming out of the general body of the bone. Okay, so this is a beak-like process, so hence we call this as the coracoid process. Okay, so you can appreciate that the clavicle lies horizontally and the lateral end of the clavicle lies above the coracoid process. Okay, so the lateral end of the clavicle lies above the coracoid process. The other process that the clavicle articulates laterally, this whole process posteriorly is known as the spine, but the outermost part of the spine, this is known as the acromion process of the scapula. What process is this? Acromion process. Okay, so if you can see, this is the left scapula. Fine. So now we have come to the see the location of the clavicle with the surrounding bony prominences around it, and more medially the clavicle will lie, the clavicle would lie above the first rib. Okay, I've got the other rib, but just for other issues, just understand that the clavicle lies above and very close to the first rib. Yeah, like this somehow. Okay, so that is with the location of the clavicle. Now coming to the anatomical position, briefly you could understand the shaft, the medial end and the lateral end. Okay, now the shaft, once we finish the presenting features of each part, then we'll try to keep it in the anatomical position. Okay, I think we can do it now also. So the medial end is facing medially, the lateral end is facing laterally, but you would actually supposed to know which is the superior surface and the inferior surface. Okay, otherwise, not to confuse you, but I can just turn this bone around and say that this is the right clavicle. Okay, which is not correct. Okay, because the shaft of the bone, if you see, is not straight like other long bones. How is the shaft of the bone here in the clavicle? How can you appreciate it as?
S-shaped curve.
Very good, sinusoidal S shaped. Some books even refer it to as F shape, italic F. Okay, curved. So, and this curvature, how is it? It's not like an arc, right? It's S shaped, like you said. So the S, the anterior surface or the anterior border. The anterior border is slightly, how is the curvature in terms of convexity or concavity? Convex anteriorly. Excellent.
Convex forward.
Yes, convex anteriorly or convex forward. Okay, and as you trace your hand or as you trace along this anterior convexity, you find that at one junction this convexity ends and a concavity begins, right? So for studying purpose, the shaft can be divided into a medial 2/3 and a lateral 1/3, depending on the curvatures, change in the curvatures. All of you agree? So if you just skip to the PPT, in this picture of the right clavicle, this is the quadrilateral medial end, the flattened lateral end. Okay, and then you can appreciate one of the surface, that is the superior surface, is very smooth. Okay, then if this is the superior surface and this is medial and lateral, this will be the anterior border and this will make it the posterior border. So the anterior border along the medial 2/3 is convex anteriorly and along the lateral 1/3 is concave. Okay, so there is a change in the direction of the shaft. Okay, so similarly, if you go to the trace the posterior border from the medial end, it is concave and then becomes convex. All of you agree? This is the superior surface. Similarly, for the left clavicle, the superior surface is relatively or usually very smooth. Why do you think this happens? Any reasoning from your end? Some point which I missed to say?
Because the superior surface is subcutaneous.
Excellent. Yes. Attachment of tendons or muscles will cause the roughened areas that you can see. If you can just switch to the video. Not the video, the other, the second screen. These roughened impressions are because of the attachment of muscles and ligaments. Okay, even below, if you can see, this tubercle, these ridges are because of attachment, because of the pull of muscles or strong ligaments. Okay, when there is nothing attached, when there is no stimulus to the periosteum of the bone, it would be calm and it would stay smooth. Agree? Like someone correctly said that the superior surface is smooth because it is subcutaneous. So we can all palpate the shaft of the clavicle in all of us. Okay, so the superior surface is smooth because it is subcutaneous, and to be more precise, there is a subcutaneous muscle. What do you mean by a subcutaneous muscle? That means there is a skeletal muscle lying in the superficial fascia over the clavicle. Yes, within the superficial fascia. If you go under the superficial fascia, you are no longer subcutaneous. You are no longer very closely beneath the skin. You will be in relation to the deep fascia. Okay. So there is a muscle which we will see in the later slides. That muscle in the region of the pectoral and the neck, this muscle is known as the platysma. Okay. If you clench your teeth, can anybody see? Appreciate? You clench your teeth, you can see the platysma becoming very prominent. Okay. It's a subcutaneous muscle, and an interesting fact here is this muscle is very well developed in, I would not say this muscle, but this sheet of skeletal muscle within the superficial fascia is very well developed in herbivorous animals. Okay. And this sheet is known as panniculus carnosus. Okay. This sheet is known as panniculus carnosus. So what would be the function of this sheet? Because it's a skeletal muscle and it is just right under the skin, with the twitchings, like if there is an external stimulus to that region, this skeletal muscle, when it twitches, that stimulus can be taken off, like in herbivorous grazing animals. Okay. So in man, this sheet is totally absent except in certain areas. Okay. And one such area is in the region of the neck, to maintain the contour, to keep the skin very adherent and give the contour of the neck. Okay. That muscle is the platysma, which is a remnant of which layer?
Panniculus carnosus.
Excellent. Panniculus carnosus. Okay. Another interesting fact, some of the skeletal muscles in the face, because you are able to move the skin over your face, right, for facial expressions and for the sphincters that are present in the face, like around the eyes, around the nose, around the mouth. These are the skeletal muscles, which are also the other remnants of this same layer. Okay. So because of this reason, the superior surface being subplatysmal, subcutaneous, palpable, okay, the surface is smooth. All of you should be able to appreciate. Okay. Because differentiating between the superior and inferior surface will lead you into wrong identification of the bone. So again, just to summarize, we've said it's a long bone, so it has a shaft and two ends. The medial end you can differentiate because it is much more enlarged and quadrilateral, whereas the lateral end is more flattened. Okay. Then the curvatures, the anterior 2/3 of the shaft is convex anteriorly, whereas the lateral 1/3 it is concave. As this picture depicts, this is the smooth surface, hence this would be the superior surface. Not very clear here in the inferior view. Okay. But still you can make out something here, and this roughened area over the lateral aspect. Okay. This is the inferior surface of the clavicle. Okay. The inferior surface, I don't know if you can see in the next screen. Can you appreciate that in the middle 1/3 of the shaft there is a slight longitudinal depression? What can we call this longitudinal depression? What is any depression which is more linear called? General anatomy, excellent. Yes, it's a groove. Okay, it's a groove. Very good. So groove is a depression, and it can have slightly raised edges, right? So this groove is known as this groove receives the insertion of a muscle, receives the attachment of a muscle. So this groove is named after that. Okay, so the muscle here is the subclavius. Okay, this muscle is the subclavius, a muscle that lies below. Okay, a muscle that lies below the clavicle, subclavius. Okay, so the groove, this groove is named as the groove for the subclavius muscle, and it has two borders, an anterior lip and a posterior lip. Okay, so if you trace, and this groove is usually present only in the middle 1/3. Okay, laterally, medially it's slightly obscure. In the middle 1/3 this groove is very well marked, and if you trace the groove more, if you trace the groove more laterally, the groove will end in this, what can you call this as? Another general anatomy term for osteology. This would be the Karthik, what is a fossa? Fossa is again a very shallow depression. Groove is a slightly deeper depression, whereas a fossa is a shallow depression which is more wider. Okay, so this, yeah, I agree. Okay, this part seems to be, but still it is the groove. This subclavian groove ends into this pointed projection. Excellent, that is a tubercle. Okay, this tubercle, we call it, depending based on the name of a ligament that is attached at this place. Okay, so this, there is a ligament here. There is a ligament here that is attached from the undersurface or the lateral 1/3 of the clavicle to the coracoid process. Okay, so what can we name this ligament as? Because it's attaching the coracoid process with the lateral 1/3 of the clavicle inferiorly. Excellent.
Coracoclavicular.
Excellent, yes. As the name goes, coracoclavicular ligament. Okay. Ashish, sternoclavicular means the ligament should be between the sternum and the clavicle. So you can expect a sternoclavicular ligament on the medial side. Excellent. No need to be sorry. Okay, so this coracoclavicular ligament has two parts. Okay, depending upon the shape of the ligament, they have given it as two names. Okay, the first and foremost, the ligament attaches. I'll show you further pictures. The ligament attaches as two bands. Okay, one band is conical and the other band is roughly trapezoid or trapezium in shape. So that conical ligament comes for its attachment here. So what can we call this tubercle as? I'll help you. We call it as the conoid tubercle. Okay, all of you can appreciate. This is the conoid tubercle, because the conoid part of the coracoclavicular ligament attaches here. Obliquely, as you move laterally and forwards, we find a ridge. See, it's difficult. This is, yeah, this is the anterior. So from posterior, you can appreciate that there is a ridge that is directed laterally but forwards. Okay, this is known as the other part of the coracoclavicular ligament, which is trapezoid in shape. So this ridge which gives attachment to the trapezoid ligament is called as the trapezoid ridge. So far clear? Should I repeat anything? Yes, okay. Repeat. For that, okay, can you This is the superior surface because it's relatively smooth, but you can appreciate this roughening. This is because of the attachment of a very powerful muscle. Because of the pull of the muscle, the periosteum here has raised. Okay, but rest of the surface is of the superior surface is relatively smooth. Okay, but here if you can appreciate, this is the posterior border at the junction of the medial 2/3 and lateral 1/3 posteriorly. This is the region of the conoid tubercle, but on a inferior aspect. Okay, here this is the inferior. So at the junction of the medial 2/3 and lateral 1/3 on the posterior margin is the conoid tubercle, and from the conoid tubercle, if you can appreciate this obliquely directed ridge, the direction of the ridge is such that it is going laterally but also forwards. Okay, this ridge is known as the trapezoid ridge. Okay, and these two structures, the conoid tubercle and the trapezoid ridge, give attachment to a ligament, that is the coracoclavicular ligament. Okay, we will see that later. Coming to the medial end, in the medial end on the inferior surface, you can see a small smooth surface. This is the articular surface of the medial end of the clavicle, which is going to be articulating with the costal cartilage, first costal cartilage. Okay, and any other, can anybody identify? Maybe this was your first class, but still try to take a guess. Where's my pointer? Yeah, can anybody appreciate this? Where's the pointer again? Here. Why does the pointer disappear? Excellent, yes, it is a foramen, like it's a hole. Excellent, Pankaj, yes, it's the nutrient foramen. Okay, so what is the function of the nutrient? What is the purpose of the nutrient foramen? It is the passage to allow a blood vessel to feed and supply and help in ossification of the clavicle. Okay, so this is the nutrient foramen. Yes, so can you see the direction of the nutrient foramen? It's more like an arrow this side, and then it's like a comet. It's going, and then this is the gases behind. Yes, excellent. Yes, it's facing laterally. Yes. Manit, if you can appreciate, it's like a comet which is trying to go laterally with the leaving the gases behind. So so we say that the nutrient foramen is directed laterally. So in general anatomy, so what will be the opposite direction? The opposite direction of the nutrient foramen indicate the growing end of the bone. Excellent. Yes, excellent, excellent. So the growing end of the bone would be the medial end. Yes, very good. Then in the middle 1/3, yeah, can you appreciate this roughened area here? This is the attachment for another ligament, and what could that ligament be by its name? Because this is the inferior. Yes?
Ma'am, please repeat because your audio was gone.
I know. I stopped. So tracing the features on the inferior surface, from medial, on the medial end, close to the, on the inferior surface of the shaft, close to the medial end, we have a small oval smooth area, that is for the articulation of the first costal cartilage. As you come more posteriorly, here you can see there is a small roughened area. This area is usually for the articulation of a ligament as the first rib lies, as the first rib lies very below the clavicle, the ligament here would be the costoclavicular ligament. Okay. So, this area is for the attachment for the costoclavicular ligament. As we move more laterally, we approach the middle 1/3 of the inferior surface. The middle 1/3 of the inferior surface has a very important structure. One is the nutrient foramen and also the groove for the subclavius muscle. As the groove ends, we reach the junction of the medial 2/3 and the lateral 1/3 of the bone. At that junction, we have a projection known as the conoid tubercle. Yes, conoid tubercle, and moving anteriorly or forwards and laterally is an obliquely placed ridge, and this ridge is the trapezoid ridge. Okay. Yes, trapezoid ridge and conoid tubercle. Okay. So, those were pictures of the bone where you cannot appreciate the markings much, but this is a schematic diagram where you can appreciate. So, can you identify which bone this is, which side it belongs to? Excellent. Right. Okay. Yeah, because the medial ends are placed medially, lateral end is flat laterally, the superior surface is smooth, and the curvature of the anterior 2/3 is convex anteriorly. Okay. So, with these, keeping the bone in these 6, seeing that the bone meets these 6 cardinal directions criteria, we can determine the side of the bone. Okay. So, now we are studying the right clavicle. So, this is the superior surface, the anterior border, the posterior border. But as the shaft is roughly cylindrical, there is no clear cut difference between the surfaces and the borders. Okay. So, we have a superior surface, an anterior surface, a posterior surface and a inferior surface. Okay. The anterior surface, as it receives attachment of powerful muscles, it forms these bony projections, these bony markings. Okay. Now, coming to the inferior surface, you can appreciate this is the area for the costoclavicular ligament. Okay, in the anterior 1/3. In the middle 1/3, you can appreciate the subclavian groove with its ridges. Then you can appreciate the conoid tubercle here and the trapezoid ridge. Okay. And then this is the lateral end. The lateral end has a oval smooth articular surface. Okay, to articulate with the acromion process. Now, coming to the various, we have seen the parts, the features that are present. Now, we will come to the muscles that are attached to the clavicle. Along the anterior surface, the attachment is for a large muscle of the pectoral region known as the pectoralis major. Okay. The pectoralis major, the fibers that attach to the clavicle are known as the clavicular fibers or clavicular head. Okay. So, most of the anterior 2/3 of the shaft gives attachment to the pectoralis major muscle, mostly along the anterior border, sometimes even across the superior surface. Coming to the lateral 1/3, along the anterior border, we have the attachment of another very powerful muscle, acting at the shoulder joint, that is the deltoid muscle. As the name indicates, this muscle is in the form of a delta, so we name it as the deltoid muscle. Going more on the posterior border, along the medial 1/3, we have the attachment of a muscle which is the main muscle in the neck, known as the sterno, because it has two heads. One head getting attachment from the sterno, another head from the clavicle, that is the anterior 1/3 of the posterior border or surface of the clavicle, that is the clavicular head, and this muscle going backwards to get inserted into the base of the skull along the temporal bone, which has a mastoid process. Okay, that's why the name of the muscle is sternocleidomastoid. Very good. So the medial 1/3 of the posterior surface gives attachment to the clavicular head of the sternocleidomastoid. Okay. Now here you can appreciate that the middle 1/3 of the posterior border and the superior surface is devoid of any muscular attachments. Okay. And this forms the base of an important triangle here, which is known as the posterior triangle. I'll try to explain to you why it is the posterior triangle. Then more laterally, along the lateral 1/3, the whole posterior and posterior border of the lateral 1/3 of the clavicle receives the fibers of a muscle which is the superficial muscle of the back, known as the trapezius. Okay. The middle 1/3 along the posterior border has no muscle attachments. So this is the trapezius muscle of both the sides. As it's roughly in the shape of a trapezium, it's called the trapezius muscle. I said platysma is a subcutaneous muscle. It is within the skin. Okay, so here you can appreciate the lateral 1/3 along the posterior border of the clavicle gives attachment to the clavicular fibers of the trapezius muscle. Yes, along the inferior surface we have the groove, the groove for the subclavius muscle. The groove for the subclavius muscle receives the attachment of the muscle itself, that is the subclavius muscle. So just summarizing the muscles that are attached to the clavicle: the pectoralis major attached to the anterior 2/3, the deltoid attached anteriorly along the lateral 1/3, almost encroaching little on the superior surface. Between the two there is a small gap where the bone has no attachments there. Then posteriorly along the lateral 1/3, the clavicle receives the fibers of the trapezius, and along the medial 1/3 posteriorly the clavicle receives the attachment of the sternocleidomastoid. The inferior surface, the groove, receives the attachment of the subclavius muscle. As you can see on my slide, I have mentioned another muscle, that is the sternohyoid muscle. Okay. So this is the first dissection picture you would be seeing. Here you can appreciate that this photograph shows the structures within the neck. So the neck is roughly a quadrilateral area. It is joined in the midline from the chin up to the sternum and posteriorly along the fibers of the border of the trapezius muscle. So this is a quadrilateral. Okay. The sternocleidomastoid is dividing this quadrilateral into two triangles. So a triangle that lies anterior to the sternocleidomastoid is the anterior triangle, and the triangle that lies posterior to the sternocleidomastoid is the posterior triangle. So this is the posterior triangle, whereas this region would be the anterior triangle. Okay. So the middle 1/3 of the posterior surface of the clavicle forms the base of this posterior triangle. And this small space here that you can appreciate between the pectoralis major and the deltoid, you would appreciate it better on the surface markings. This is known as a small depression, because these are two powerful muscles and the skin between them is slightly depressed. So this is again any depression, but which is larger is a fossa. So this depression below the clavicle, okay, and between the two muscles is known as the infraclavicular fossa. Any doubts so far? Yeah, I'm sorry, I wanted to show you. Yes. So here you can appreciate that this is the superior surface of the clavicle, which is subcutaneous, devoid of any muscle attachments. This shows the cut ends of the muscle. So this is the sternocleidomastoid, which has been removed. Okay. Close to the medial end of the clavicle, behind the sternocleidomastoid, you can see these muscles. Just by their morphology, how do these muscles appear? Straight, flat muscles, rectus kind of. Okay. So these are known as the strap muscles. Excellent, Ashish. These are known as the strap muscles. So one strap muscle attaching from the posterior surface of the clavicle and the sternum going all the way up to the cartilages, or the only bony elements that are present here, that is the thyroid cartilage, and another important bone here, that is the hyoid bone. So this muscle extending from the posterior surface of the lateral end of the sternum is the sternohyoid muscle. Okay. Sterno from the posterior aspect of the sternum going to the hyoid. But you can appreciate this lateral most fibers sometimes can come in relation and give attachment to the medial most part of the posterior surface of the clavicle. Yes, with that we would finish most of the muscles. We'll come to the other ligaments that are attached to the clavicle. So can you appreciate what is this region? Can you see my pointer here? Yes, a fossa below the clavicle. Yes, the infraclavicular fossa. And this infraclavicular fossa, as it lies between these two muscles, it can also be called as a deltopectoral groove. Sorry, deltopectoral fossa. In this picture, you can also appreciate the various structures that are in relation to the clavicle other than the muscles and the ligaments. Ligaments we will be seeing. Okay. So closely along the midline, deeper to these strap muscles, you can even palpate in yourselves. You can feel the tracheal cartilages, sorry, the laryngeal cartilages continuing below as the trachea. So most medially you will have the trachea, on either sides you have these neurovascular structures. Can you appreciate just by gross anatomy what could you label this as? Where my pointer is? From the tissues?
Carotid artery.
Just by gross appearance. So what is this and what is this? Is there a gross difference between these two? Yes or no? One appears to be collapsed, it is very thin, the wall is crumpled like. Yes.
Vein and artery.
Yes. So this medial structure, right, left, no.
Medial one is artery. And
Excellent.
lateral one
Yes, yes, yes.
And the lateral one.
Yes, medial one. So anything close to the midline is medial. So this is the artery, and more lateral, this is the vein. Okay. So these structures that are entering, they are going upwards or coming down, but targeted cranially. So this will be the common carotid artery dividing, okay, into internal and into external and internal carotid, and this is the vein, internal jugular vein. Okay. And more behind, can you see all these nerves? Can you see? These are white, glistening, they have no lumen and they are flattened. Where's mine? Yes, these are nerves. Okay. And you can appreciate this, these are the nerves. Okay. All these important structures are related to the clavicle. So any anomaly or any pathology to this bone here can cause damage or cause symptoms that are not normal. Yes. So again, just revising the structures that are related to the clavicle, more medially trachea, then more laterally the subclavian vessels, the subclavian vessels entering laterally, then the common carotids more above, but mostly here the brachiocephalic trunk, the brachiocephalic veins, more laterally the subclavian vessels, and these nerve plexuses that are going more deep. Okay, we shall see them as the plexus.
Dr. Harisha, I think this is digressing a little. Let's just come back to the clavicle and pectoral region.
Yes,
We'll
yes,
leave
ma'am.
that for him.
Okay, yes, ma'am. Yes, ma'am. So now we have seen the bone muscle attachments. Now just coming to the ligaments and the joints. So the medial end of the clavicle articulates, the medial quadrilateral articular surface articulates with the sternum. The sternum we know has three parts. Yes, the sternum has three parts. Yes, a manubrium
Manubrium body
and
and
xiphoid process. Yes, xiphoid process. Yes. So the medial end of the clavicle articulates with the manubrium sternum. Okay, clavicular fossa of the manubrium sternum to form the sternoclavicular joint. Okay. So when you are describing joints, we describe them under certain headings. First and foremost, just like the bone, classify the joint. Okay. So this you can classify based on the articular surfaces and the movements and all there, right? Very good. Yes. So it's a saddle variety of synovial joint. So basically it's a synovial joint of the saddle variety. So this is the articular surface. The articular surface of both the areas are covered by fibrocartilage, and the joint cavity is completely divided by a intra-articular disc. Okay, fibrocartilaginous intra-articular disc. All of you can appreciate in this picture. So the sternoclavicular joint is a synovial saddle variety of joint, but for all synovial joints the articular surfaces are very good. Yes, articular surfaces should be covered with hyaline cartilage, but here the articular surfaces are covered with fibrocartilage, and also there is a fibrocartilaginous intra-articular disc. So this joint is finally a complex saddle synovial type of joint. Okay, the other small, now coming to the bones forming the joint, between the articular medial end of the articular surface of the medial end of the clavicle with the counterpart on the manubrium sternum, but the small part mostly inferiorly. Why is it complex? Because the simple joint is divided by an intra-articular disc. So inferiorly, the first costal cartilage is also taking part and giving attachment to the articular disc. Okay, so there are more than 2 bones taking part in the formation of this joint. Some books even refer to this attachment between the cartilage and the clavicle as a separate joint itself. Let's not go there. So we've seen the bones forming the joint. We've talked about the articular surfaces. Okay, the articular surfaces are smooth, but because it's a saddle variety, not because it's a saddle variety, because of the articular surfaces, the direction of the articular surface is such that it is convex vertically and concave in a anteroposterior direction. Okay, that makes it a saddle variety. And because of this intra-articular disc, there are different movements happening in the 2 joint spaces. The margins of the articular surfaces usually give attachment to one structure. What would that be? Here can you appreciate? The margins of the articular surface give attachment to the capsule of the joint, and lining within the capsule of the joint we will have the attachment of the synovial membrane. Yes. Okay. So the margins of the articular surfaces of the clavicle give attachment to the synovial membrane, and more on the periphery attachments of the capsule. Inferiorly, the intra-articular disc is attached to the capsule and also to a ligament that is attaching the first costal cartilage with the undersurface or the inferior surface of the medial end of the clavicle. This ligament is known as the costoclavicular ligament. So these are additional ligaments or external ligaments which are reinforcing the joint capsule. And this ligament, can you appreciate it? Going between the sternum and the clavicle, strengthening the capsule externally, that is anteriorly, superiorly. This ligament is known as the sternoclavicular ligament. But on the superior aspect, if you can see this part attaching the 2 clavicles, right? These ligaments, this ligament is known as the interclavicular ligament. So primarily the capsule of the sternoclavicular joint is strengthened by the sternoclavicular ligament, and inferiorly it is strengthened by the costoclavicular ligament, and superiorly by the interclavicular. But the main ligaments are the sternoclavicular and the costoclavicular ligaments. The costoclavicular ligament, can you appreciate its extent? From the junction of from the first costal cartilage, the rib, to the medial 1/3 of the inferior surface of the clavicle, this ligament is attached in or is placed in two planes, okay, an anterior lamina and a posterior lamina. The direction of fibers of these ligaments will determine the range and the direction of motion, okay. And another important thing we will see later, how it also helps in transmitting weight. So here also in this picture you can appreciate the articular cartilages, intra-articular disc merging with the associated with the sternoclavicular joint, okay. So coming to the next topic, that is the blood and nerve supply of the joints and the clavicle. So the surrounding structures usually supply the blood and the blood, that is the arterial and venous supply to the clavicle, and these are mostly the artery to the upper limb is the subclavian artery. Beyond the first rib, the subclavian artery continues as the axillary artery to enter into the axilla, okay. So from the axillary artery we have a branch, that is the thoracoacromial artery. That artery gives out branches, clavicular branches, to give blood supply to the clavicle and the structures surrounding it. And we also have branches from the subclavian artery itself. These are known as suprascapular arteries, and these give nutrition to the bone. The nerve supply is by supraclavicular nerves, which are cutaneous nerves coming from the cervical plexus, okay. Then the factors that maintain the stability of the joint are mostly the capsule which is strengthened by the extrinsic ligaments. So the main stability of this joint is by this costoclavicular ligament, okay. So the weight transmitted from the upper limb through the clavicle is passed along this, is carried by the costoclavicular ligament and given to the sternum or the axial skeleton. Yeah, once I get a picture now, I will try to tell you the blood supply. Just a minute, okay. So as this is a saddle variety of joint, it can cause gliding motions, okay, and also when the scapula or the shoulder joint is abducted slightly beyond 90 degrees, that time with every scapular movement there is movement at the sternoclavicular joint, and this is the axial rotation. Okay, so the joint moves anteroposteriorly, gliding as well as along its long axis, that is axial rotation. Then the intra-articular disc acts as a shock absorber, cushion, shock absorber for between these two articular surfaces, and helps in, not helps in, but keeps the joint stable. Otherwise, if there was no intra-articular disc, the pressure between these two would not allow the movement. Then coming to the applied anatomy. What is applied anatomy or clinical anatomy? Anything related to the anatomy here, which can go wrong, okay. So with undue stress on these ligaments and on the shaft of the bone, what can happen in relation to the joint? The ligaments can rupture one, okay. So when there is a rupture of the ligament, the stability is lost. So when the stability is lost, the two articular surfaces are not held or approximated. Okay, so that can lead to dislocations or subluxations of the joint. But the sternoclavicular joint, because the articular surfaces and the ligaments are so close to each other and such strong ligaments, and because they are strong, because they are subjected to that much weight and stress, they are very strong. So the dislocation of the sternoclavicular joint is considered very, very rare. Okay, unless in prolonged weight bearing, like in people who bear weight over carrying on their head with the arms abducted and overhead abduction, with undue stress, there can be a rupture of the costoclavicular ligament leading to anterior or posterior dislocation of the sternoclavicular joint. Okay, so when there is posterior dislocation, the structures that are related behind the medial end of the clavicle, like the trachea and the subclavian vessels, they can get compressed. Okay, and can lead to neurovascular deficit. If the trachea is compressed, you can have difficulty in breathing. Shall we go to the next joint? The next joint is the acromioclavicular joint. The acromioclavicular joint is a synovial joint. As the articular surfaces are flat and closely approximated, it is a plain synovial joint, but the joint cavity is again divided by an intra-articular disc, fibrocartilaginous intra-articular disc. Okay, so the bones forming the joints are the articular surface of the lateral end of the clavicle and the medial end of the acromion, articular surface of the medial end of the acromion process. The articular surfaces are, the direction is antero-posteriorly oval, allowing gliding movements. The capsule is attached to the margins, and the ligaments that strengthening the capsule are the acromioclavicular superior and inferior acromioclavicular ligaments, and another important ligament attached to the lateral 1/3 of the inferior surface of the clavicle to the coracoid process, which is the coracoclavicular ligament. In this image, you can appreciate the coracoclavicular ligament is attached as two bands, the conoid part and the trapezoid part. All of you can appreciate. And this ligament is very strong compared to the acromioclavicular ligaments and helps in transmission of weight. Okay, so when you are carrying weight, as the upper limbs have to freely move by the side of the trunk, the weight is transmitted through the skeleton of the upper limb to reach the upper end of the humerus, then transmitted through the head to the glenoid to the scapula, from the body of the scapula transmitted to the coracoid process. The weight is then, the forces are transmitted through the trapezoid and conoid parts of the coracoclavicular ligament, then taken over to the medial 1/3 of the clavicle, and as you approach the anterior 1/3 of the medial 2/3 of the clavicle, the forces of transmission are carried by the costoclavicular ligament and the sternoclavicular ligaments, but the costoclavicular ligament has a major component, and then transmitted to the sternum. So this is the line of weight transmission, which is very important, you should be able to answer. Okay. So again I am repeating, the weight is brought by the appendicular skeleton bones reaching up to the humerus, transmitted to the scapula, from the scapula to the coracoid process, to the coracoclavicular ligaments, going along the medial 2/3 of the bone of the shaft, then transmitted to the costoclavicular ligaments and to the sternum. I couldn't get a complete picture, sorry, so I had to move slides. So this is the weight of transmission. Everybody understood, or do you want me to repeat again? Understood. Thank you. Yeah. So this is I wanted to show you this for the blood supply of the clavicle and the joints. Okay.
Excuse me, ma'am.
Yes, sorry.
In the previous slide, there was a picture of acromioclavicular ligament.
Yeah,
So
yeah.
Isn't the picture coracoacromial ligament, or because between acromial process and clavicle there is a capsule.
Sorry, I didn't get you. Can you repeat?
Between the acromial process and the clavicle there is supposed to be a joint capsule, but in the heading it's written as a ligament.
This acromioclavicular ligament?
Isn't it joint capsule?
The joint capsule is very thin usually for all the joints. The joint capsule is always strengthened additionally by these extrinsic ligaments.
Right.
If I would have got a section like you have here, then maybe it would be more explanatory. But because it's a plain synovial, very thin joint, and the articular surfaces are so adherent, you don't get a very good section usually, or an image. Okay.
Okay, ma'am.
Okay.
Thank you.
Okay. So the acromioclavicular ligaments, there are two, a superior and an inferior. Okay, strengthening the capsule. Here. This is a totally different ligament which is in relation to the shoulder joint. Right now we are dealing with the articulations of the clavicle. Okay. Yeah. So the blood supply is from the blood vessels that are surrounding. When we do the pectoral region, I have a better picture because all these arteries and names and their direction will be a little new to you. So I will try to cover the blood supply because the clavicle and the muscles here are also covered in the pectoral region. So I will be able to explain to you better there. Is that okay? But you can appreciate these three structures here. What are they? These are the cutaneous nerves. Okay, supraclavicular nerves. These are coming from the cervical plexus. Okay, mainly from the cervical 3rd and 4th segments. Okay, C3, C4. So they are carrying those fibers from that level of the spinal cord to give innervation, cutaneous innervation to the skin over the clavicular region. Okay, and sometimes one of this, which is usually the intermediate supraclavicular nerve, can be very closely related to the periosteum of the bone and appears to be piercing the clavicle also. So that also makes it another important unique feature of the clavicle, that usually we don't hear of any nerve piercing the periosteum of a bone, right? But there are some studies that show that this intermediate, where's my cursor? The intermediate supraclavicular nerve can pierce the middle 1/3 of the clavicle. So the nerve supply will be by these supraclavicular nerves. Another very important topic of the clavicle is the ossification. Okay, just like roughly brushing up, usually there are two types of ossification. Like if there is a preformed cartilage model and then over the cartilage calcium is deposited to form, that is an endochondral type of ossification. Suppose there is a preformed membrane over which the calcium is deposited, that is known as a intramembranous type of ossification. Okay. So the clavicle, though is a long bone, has intramembranous ossification. Okay. So there is the mesenchyme over the clavicular region condenses, okay, and within this mesenchyme primary ossification centers, two primary ossification centers appear at around the 5th to 6th weeks of intrauterine life. Okay. These two centers start developing or depositing calcium or start ossifying, and they two unite and form a single and start laying down the shaft of the bone. Okay. Then at around 18 to 20 years of life, two secondary centers or mostly one secondary center appears along the medial end of the clavicle. The lateral end of the clavicle, the secondary ossification center is inconsistent. So this secondary center appears at around 18 to 20 years of age and starts laying down or starts ossification to meet the shaft. Okay. And this fusion of the primary and the secondary centers usually occurs at around 25 years of age. Okay. As the bone, the secondary centers of the medial end unites, appears first and unites last with the primary center, the medial end of the clavicle is known as the growing end. Okay. This is about the ossification of the clavicle. So the applied anatomy here could be, there could be some genetic conditions where these ossification centers don't develop, along with many other intramembranous bones in the vicinity of the clavicle. So when such a condition appears, the clavicle is absent or underformed, underdeveloped. Clavicle is intramembranous in ossification. Some part, like by adult, if you can see that the cancellous bone could be replaced, and in few studies they have shown that the medial end of the clavicle has a medullary cavity, but that is slightly controversial. If it has a medullary cavity, then we could assume that it is an endochondral, but majority they haven't found a medullary cavity within the bone, so it is intramembranous ossification. Is that okay? So there are few important unique features regarding this. It is a long bone, but it is placed horizontally, right? And it's a long bone which is ossifying intramembranous. And another important thing, okay, that the shaft has two primary centers. Unlike other long bones, usually the shaft has one primary center. Okay. And another unique feature is the clavicle is the first bone to ossify, because usually the primary ossification centers usually appear around 7 to 8 weeks of intrauterine life. But the clavicle, as it is the first bone, the primary ossification centers appear at around 5th to 6th week of intrauterine life. And another important feature here is another important feature here is that as the bone is placed just in relation to the skin, it is rarely going to go for any fractures, compound fractures. Okay, we'll come to that. Yeah, so coming to the fractures of the clavicle. It's a long bone, it is helping in weight transmission, but mostly the medial 2/3 of the bone is taking part in the weight transmission. The lateral 1/3 is somehow excluded because of the attachment of the coracoclavicular ligament. Okay. So, as the weight is transmitted along the medial 2/3, okay, when there is a break, usually when the bone is curved, there is the direction of force has to change. So, when there is a change in the direction of force, that point where there is change makes the bone the weakest, right. So, the fractures of the clavicle are most common at the junction of the medial 2/3 and the lateral 1/3. And another important feature, yeah. So, this is an X-ray of the right shoulder region showing a fracture of the clavicle at the junction of the medial 2/3 and lateral 1/3. The presenting features of the clavicular fracture are that mostly it is a simple fracture, okay, because the clavicle is subplatysmal. So, the platysma moves the skin around the clavicle. Is when you are sustaining a fall, you try to stop yourself from falling, right. So, your position is that you are landing on the floor on an outstretched hand, right. So, the contact with the ground, from there starts the transmission of weight. So, it again comes back through the humerus to the scapula to the coracoid process, coracoclavicular ligaments, medial 2/3. Okay. So, this is the region where there is change in the direction of force, and hence this is the region where there is most common fracture of the clavicle. The most common method of this mode of fracture, the mechanism is when there is a fall on the outstretched hand. And another thing, what I said, that mostly these fractures are never compound. Okay. And when there is a fracture, what happens to the fragments? This would be the medial fragment and the lateral fragment. The lateral fragment, which is attached to the acromion and the shoulder joint, because of the weight of the upper limb, is displaced downwards. Okay. Because of this displacement, the medial end is dropped down, falls down. Okay. So, this is another applied anatomy. This is the region of the sternoclavicular joint. Difference between simple and compound. Compound fracture is when the fracture is exposed to the external environment. That means when the structure surrounding the fracture, be it muscles, skin, anything, are ruptured and expose the bone fragments to the external environment, we call that kind of a fracture as a compound fracture. Okay. When there is a fracture and everything, the skin, muscles, all are intact, that is known as a simple fracture. Okay. So, now here you can appreciate this is the lateral end of the clavicle and this is the acromion process. And what could this be? Anybody can appreciate this? Yes, very good. So, this is the coracoid process. So, you can appreciate here that the two bones are no longer congruent. So, they are displaced, and so this is the dislocation of the acromioclavicular joint. So, we said that the clavicle is related to the structures that are present in the neck and structures that are entering into the axilla, namely the subclavian vessels and the nerves entering into the axilla, and the structures entering into the axilla, namely axillary artery and vein. Okay, and the space between the clavicle and the rib is very small, and is also bridged by the subclavius muscle. Okay. Into this space, if there is an additional rib, okay, that rib is known as the cervical rib. Any rib, the ribs are nothing but an extensions of the spine of the transverse processes of the vertebra. Okay. So the extension of the first thoracic vertebra is the first rib. But if there is an extension in the cervical, then that region we call it as a cervical rib. Cervical ribs are not going to look exactly like a rib. They will be just a small osteofibrous element, okay, and such an osteofibrous element can compress the neurovascular structures in this area in close relation to the clavicle, okay, and then can cause neurovascular deficits. Similarly, beyond the 12th rib, if there is a rib coming from the lumbar vertebra, that would be known as a gorilla rib. Okay. So now here you can appreciate these are the sternocleidomastoid muscles going for the insertion into the sternum. Here you should be able to appreciate the sternal notch of the sternum, okay, but you are not able to appreciate it because the medial end of the clavicle has come forwards and medially. Okay. So here there could be a rupture in the costoclavicular ligament or the sternoclavicular ligaments, okay, and hence this sternoclavicular dislocation. So with this we finish this first lecture on the clavicle. So as a quick summary, you should be able to identify the clavicle first and foremost, okay, which everybody usually does because it's the first bone they study. Then the two ends of the clavicle, the medial and the lateral end, the curvatures, the surfaces and the features on each surface. And how do you determine the side? We've said, right, depending on the curvatures, depending on the curvatures. Then anatomical position, this I have to mention to you, okay. Okay, the anatomical position is after you've determined the side, how the clavicle is placed in the anatomical position, okay. So in the anatomical position, the clavicle, the medial end of the clavicle is directed anyways medially, is slightly downwards and forwards, okay. So if you keep the medial end slightly downwards and facing forwards, that will place the clavicle in the anatomical position. Any doubts here? Quickly just go through. You should be able to articulate, talk about the articular surfaces, the muscles, then the structures related. We will talk about the blood supply and innervation of the clavicle, the ossification and the applied anatomy. Finally, the unique features. Did we do the unique features? Sorry. Yeah. Just quickly go through the unique features of the clavicle. It is horizontally placed unlike other long bones. It is a long bone with intramembranous ossification we discussed. So it has the absent medullary cavity. It is the first bone to ossify as its primary centers appear much earlier than other long bones. Then it is a bone that is placed and mostly entirely along its length, subcutaneous and subplatysmal. It is a nerve that is closely related to cutaneous nerves, okay, not mixed other nerves. Yeah. And another point is that it has no component or counterpart with the pelvic girdle, and as it is as fall on an outstretched hand to protect yourself is so common, it's also one of the most common bones for fracture, and the site of fracture is at, what is the site of fracture?
The junction between the lateral 1/3 and medial 2/3.
Excellent, okay. Junction. Okay, here what can you identify? What is this arrow? Sternoclavicular, sternocleidomastoid. Sternocleidomastoid, correct, correct. And posteriorly you can appreciate the trapezius, and here you can appreciate the middle 1/3 of the clavicle. And these are the strap muscles which are reflected. Okay. Would you like to take a break?
Harisha, this was very well done. I just wanted to clarify a couple of things.
Yes, ma'am.
The clavicle, if you could just hold up the clavicle or show the image of the clavicle once.
Yes, yes, ma'am.
The clavicle has a medial 2/3 and a lateral 1/3. The medial 2/3 is actually quadrangular in section, and it has superior, inferior, anterior, and posterior surfaces. The lateral 1/3 is flattened from above downwards, and therefore it has only two surfaces, superior and inferior, and two borders, anterior and posterior. Very often we do call the continuation of the anterior border towards the medial 2/3 as the anterior border, but it's really the anterior surface, right? And the borders of the medial 2/3 are rounded, and there is no well sharply defined border that we describe, right? So medial 2/3 and lateral 1/3. Medial 2/3 quadrangular in section, superior surface, anterior surface, inferior surface, posterior surface. The superior and anterior surfaces of the medial 2/3 are roughened for muscle attachments. The posterior and the inferior surfaces are relatively smooth because structures have to pass. It comes in contact with the inlet of the thorax and with the lower down with the structures of the thoracic cavity, mainly with the inlet of the thorax. The lateral 1/3 as anterior border, again roughened for attachment of deltoid, a posterior border for attachment of trapezius. Superiorly also these muscles extend onto the superior surface, and inferiorly a conoid tubercle and a trapezoid ridge, which gives attachment to that very strong ligament which is known as coracoclavicular ligament. So here we can see the conoid tubercle and the trapezoid ridge, and we will later, when we do the demonstration of the scapula, find that on the superior aspect of the coracoid process, again we have the conoid tubercle and the trapezoid ridge for the attachment of the same ligament. This is a very important ligament, the coracoclavicular, excellent, coracoclavicular ligament, very nice. So here it is visible. It has two parts, the conoid part and the trapezoid part. So the two parts of the coracoclavicular ligament get attachment on the inferior aspect of the lateral 1/3. Now the medial 2/3 includes the middle 1/3, and that middle 1/3 on its inferior aspect has a kind of a slit-like, sometimes well-defined, not sometimes well-defined, subclavian groove, which gives attachment to the subclavius muscle. That's right. So it gives attachment to the subclavius muscle. So otherwise it's fine. So here in this picture the subclavian groove is very well defined. Can you just outline it for them? And this subclavian groove will give attachment not only to the subclavius muscle, but its margins will give attachment to the clavipectoral fascia, which you are now going to deal with in the pectoral region. And for side determination, the anatomical position was very well explained. For side determination, what they have to understand is that the medial end is bulky and quadrangular. Laterally, it is flattened from above downwards. The anterior 2/3 is convex forward. The medial 2/3 is convex anteriorly. The lateral 1/3 is concave anteriorly, and the posterior aspects of the same medial 2/3 and lateral 1/3 are in the opposite way. The medial 2/3 posteriorly is concave, and the lateral 1/3 posteriorly is convex, right? So that helps us to know what is anterior, what is medial, what is lateral. For superior and inferior, the inferior aspect presents the subclavian groove and the very prominent conoid tubercle and trapezoid ridge. And also in some clavicles you can appreciate medially a small facet where the clavicle articulates with the first costal cartilage. It was there in the previous picture, earlier picture, yeah. So medially, the lower diagram, yes, where it articulates with the first costal cartilage. And here, just outline for them, the facet which articulates with the clavicle, I'm sorry, the facet which articulates with the sternum, just outline it in both the diagrams, yeah, and the one above, very good. And then the facet which articulates with the acromion process of the scapula at the acromioclavicular joint. Fine, excellent. So now I think after 2-3 minutes water break, you can start with the pectoral region.
Excuse me, ma'am. Ma'am, what is the anatomical position you were talking about? Can you please demonstrate it once again?
Okay.
Of this clavicle.
Yeah. So look at your screens. So this is the left clavicle. I am holding it with my left hand. The shaft, medial end which is massive, quadrilateral. The lateral end which is flattened. So for anatomical position, first for side determination you have to see that the bone satisfies the 6 cardinal directions. Okay, it should satisfy medial, lateral, superior, inferior, anterior, posterior. Okay, so we have placed the medial end medially, lateral end laterally. Then the medial 2/3, the curvature is convex anteriorly, so we have done that. Then the superior surface is relatively smooth compared to the inferior. So now with this we place this as the left clavicle. We have determined its side. Okay. Now coming to the anatomical position is how the how the clavicle is placed in the anatomical position in the body. Like you know the term, what the big definition for anatomical position, right? That is when a person is standing on his 2 feet,
yes, ma'am,
with the toes forwards and the hands by the side facing the palm and the face straight with the eyes facing the horizon. Okay, in such a position how the bone is placed, that is known as anatomical position. Okay, for the anatomical position in the clavicle, the medial end is medial and the medial end also is directed slightly downwards and forwards. Okay. Yes, yes, it's oblique. It's obliquely placed because it has to even keep the scapula slightly away and give free movement to the upper limbs. That is why we call the clavicle also as the strut bone. Anatomical position is clear?
See the clavicle has to articulate anteriorly with the sternum. The sternum is anteriorly placed, but laterally, so that's at the medial end of the clavicle. Laterally, it has to articulate with the scapula or the shoulder blade. That is applied to the posterolateral aspect of the rib cage. So it has to be oblique in order to articulate with both. Yes, this picture shows it beautifully. Right? So it can't be exactly transverse. That is what Dr. Harisha was trying to say.
Yes.
The medial end of the clavicle is slightly more anterior compared to the lateral end, which is more posterior.
Ma'am,
Yes,
what did you say before? Clavicle is also called which bone?
STRU.
The clavicle is also called the collarbone.
Collarbone.
You said something
And the
strong.
scapula is also called the shoulder blade.
It acts as a strut.
Ma'am, she said some. SP.
RUCT. Strut bone. Like its function is as a strut, like a fulcrum.
Okay, what is okay, Dr. Harisha, what is a strut? Suppose there
Ji,
is
ma'am.
something collapsible, you know, a kind of it's something which, what can I mean, what example can I give? You know, something which has two parts which are normally lie in approximation to each other. Now, in order to pull them apart, you will put a stick between them, say a tweezer, a pair of tweezers, you know, plucker. So suppose you want to pull the two prongs of the plucker apart, you will put a stick between them to hold them apart. That's a strut.
Clear? Shall we go to the next? You guys, you want a break or we'll start the pectoral region?
Ma'am, blood supply.
Yeah, that we'll do in the pectoral region, okay?
Thank you, ma'am.
How many minutes break? 2-3 minutes, like ma'am said.
Dr. Harisha,
Yes.
unless you want to take a one break.
No.
Okay. I can answer the questions while you take a break.
Yes, ma'am. I'll also go
Go
through.
ahead.
Ji, thank you, ma'am.
Ma'am, please once again explain intermembranous ossification.
Intramembranous. Okay. So, the embryonic tissue, like ma'am said in the earlier classes, is the mesenchymal tissue. Okay. And this mesenchymal tissue is spread all over. Okay. In the region there has to be a muscle. The mesenchymal tissue will convert into some osteoprogenitor cells will give rise to myocytes. And in the region where it has to convert into a bone, that mesenchymal tissue will it has two fates. Okay. If it is going to be a long bone like in the appendages, it will take the form of a cartilage model first. Over this cartilage, the chondroblast cells are deposited and they will transform into chondrocytes and lay down the matrix and help in ossification. Okay. So, when there is a preformed cartilaginous model, okay, cartilage, the word for cartilage we use is chondra. So, when there is a preformed cartilage and after that cartilage takes the shape of the bone or becomes the bone, that is known as endochondral ossification. Okay, is this clear?
Thank you, ma'am.
And intramembranous is the other way. The mesenchymal tissue condenses and forms like a membrane. That membrane may again the cells differentiate into chondroblast, osteoblast, osteocytes, start laying the bone around and then form the bone. That is known as intramembranous ossification.
Essential difference between intramembranous and endochondral ossification is that in endochondral ossification there is an intermediate step of cartilage model. Initially everything is mesenchyme. In that mesenchyme there is a condensation to form a membrane and the bone forms in that membrane. That's intramembranous. But if in that mesenchyme, in the condensed connective tissue, there is a step where a cartilage model is first formed and then the bone replaces that cartilage model. That is called endochondral ossification. That is the difference. Clavicle ossifies in membrane except its medial end, which ossifies in cartilage. Which is demonstrated to every medical student, and so you begin with a tough one.
Ma'am,
Yes.
ma'am, can you show the borders and the surface of the clavicle again?
You want to see
Not
it in?
now, not
Okay.
now. Let her first do the pectoral region. In the end, she'll show you
Okay.
in the video.
Yes, ma'am. Should I play the video, Alice, ma'am?
Unless you want to demonstrate the video first.
How ma'am should I do that for him?
So I think you've already taken 2 hours on clavicle.
Oh.
Obviously, with the bone, I mean, because it's not face to face, it does take extra time. I absolutely realize that.
No.
But I think you go on to the pectoral.
Yes ma'am, I'll do it at the end.
We'll do the video.
Yes ma'am.
Yeah.
Or if there is no time, I'll upload it ma'am for the ma'am Saral.
Ma'am,
Yes?
in the unique features of clavicle,
Yes.
please put that slide, ma'am.
Why? What do you want? You can ask me.
First, do the pectoral region, then we'll do the clavicle again. Wait.
Anything in particular regarding the unique features? One thing, like ma'am said, it's the one bone that has ossification intramembranous and the medial end is endochondral. Okay. Anything else other than that? In the unique.
That no counter, that one, ma'am, that point, ma'am.
Okay. See, in the pelvic girdle, that is the girdle that articulates the lower limbs with the axial skeleton, there are two hip bones, and these two hip bones anteriorly they are articulating with each other, and posteriorly they have the articulating with the sacrum. Okay, so when you compare the pelvic girdle to the pectoral girdle, the hip bone is the counterpart of the scapula. Okay, but the clavicle, none of the features are represented in the hip bone for the clavicle. That's why we say that the clavicle has no counterpart in the pelvic girdle. It's up to you if you remember this point. Okay, when we do the hip bone, we again say that the hip bone has three different elements. Okay, two ventral and a dorsal, and these elements like there is always a segmental innervation and development. Okay, like one segment of the mesoderm will give rise to bone, muscles, and the nerves will infiltrate and supply that region. Okay, so suppose the mesoderm has divided into an anterior and a posterior. So the bone and the muscle that are developed in the ventral part will be supplied by the ventral nerves, whereas the bone and the muscle developed in the dorsal will be supplied by dorsal. Okay, so in that aspect the hip bone has a ventral and a dorsal element. Similarly in the scapula, the muscles coming from the anterior aspect or the ventral going to the scapula will be supplied by ventral nerves, whereas the muscles coming from the posterior will be supplied by posterior divisions, we'll see, of the brachial plexus. So depending on this development and nerve supply, we say that the ventral aspect of the hip bone corresponds with the ventral aspect of the scapula, and the ventral dorsal aspect same thing, but the clavicle has no counterpart there. Okay, because the clavicle is like I said, it's just like a small extra bone to free the upper limbs from the axial skeleton, so that there is increase in range of movement. It is just like there for attachment of bones and protection of structures, that's it. Okay, and when there is shoulder joint movement, it is facilitating the shoulder joint movement. There are principally no fixed movements for the clavicle. For that, by that I meant that. Okay, is this okay explanation? Should we start with the pectoral? Okay, yes. I can't see how many have logged in. What's the strength like?
137.
Yeah, okay. So now coming to the pectoral region, we just saw in the regional anatomy, the shoulder is can be studied under different aspects, and the anterior aspect is the pectoral region. The extent of this region is along the midline, okay, from the sternum up till the xiphoid process, and laterally this xiphoid process is the net there. My screen is frozen. Okay, laterally the xiphoid process, at that junction there we have the attachment of the 7th rib. Okay, so the pectoral region extends up till there in the midline. Then superiorly it is bounded or limited by the clavicle. Then laterally it is limited up to the anterior axillary fold. Okay, so this is the extent of the clavicle, and all the contents that are present, namely the muscles and the neurovascular structures, are studied in the pectoral region. Okay, because bones we usually study earlier before we go into the soft part structures. So we have studied the clavicle, the sternoclavicular, acromioclavicular joints and all. Okay, the rest of the joints that we encounter we will do more preferably in the thorax and the shoulder joint region. My screen has frozen. Okay, now coming to the contents, the muscular contents we can expect in the pectoral region is the one large muscle, that is the pectoralis major muscle, and we'll see the other muscles. The muscle, if there is a major, then a smaller muscle that lies deep to it will be the pectoralis minor muscle, and the blood supply and the nerve supply of all these structures. Okay, so as we in regional anatomy we go layer by layer, or we go in a particular direction, because we are not doing something like a systemic anatomy here. So in the skin, prior to going into the regional anatomy, you should be familiar with the landmarks, or we call them as the surface landmarks. Okay, because these bones or these areas can be easily visible and are constant in the skin here. Okay, so, in the midline you can appreciate for the pectoral region this depression over the manubrium sternum, this is known as the jugular notch. Okay, on either sides you have the medial end of the clavicle, which usually is not very prominent because it is covered by the sternocleidomastoid muscle. Okay, so this is the jugular notch. It is a notch or a curve on the depression on the bone. Okay, but the region around this jugular notch is suprasternal notch or the jugular notch. This region is known as the suprasternal fossa or the jugular fossa. Okay, then more laterally you can palpate the clavicle. Okay, then as you go laterally you can feel the broad palpable acromial process. Okay, at this junction, at the lateral 1/3, if you go 1 to 2 centimeters below, okay, and like on deep palpation, you have to like press your tip of the finger into that point 2 to 3 centimeters below the clavicle, then you can feel the tip of the coracoid process against your finger. Okay, then in the midline from the jugular notch, as you come down at the junction of the manubrium, Can I just take some technical assistance? My screen has frozen. I'm not able to go to the next slide. Okay, just excuse me. Can I log out and log in again? No technical assistance here. Ma'am?
Harisha, log out and then log in.
Yes.
I'll just call up Manmohan.
I called him, ma'am. His mobile is coming switched off. I don't have any other number to contact.
Neither do I. So, okay, log in again.
And I leave the meeting. Those who are present, can you see my screen? Can everyone see me? Can everyone see me?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So I'll just have to. Can you see the screen?
No, no.
No. How do I go to share screen?
This conference will now be recorded.
Still you can't see my screen, right?
No, we can't see it.
I am the presenter.
You have to share. You are the presenter, so just share your screen.
How do I do that, ma'am?
You know, there is an icon where you have the mic and the camera. There is an icon which is screen. You have to click on that. Below, on the lower part of your screen. LT2?
हाँ ma'am, there is.
My camera screen. So just on the right side, there is something. It's a rectangle with a which is crossed. That screen. You have to click on that.
Ma'am, that's
For
what
sharing
because that is not there. I had logged out now, so I may.
I will call the other LT attendant. Wait.
Oh ma'am, please, thank you. Huh, ma'am, I got it. Can you see my screen?
Yes.
Okay, thank you.
Yes.
Yes, ma'am, I got it. So we were saying about the surface landmarks. So this is the suprasternal notch, jugular fossa, clavicle, the lateral end. Here you can see this is the acromion, and at this junction 1 to 2 centimeters below deep you will feel the coracoid process. Then from the notch, as you come down, you can suddenly feel there is a transverse elevation or a ridge like thing, that is known as the sternal angle, and that sternal angle laterally corresponds to the attachment of the second costal cartilage and the rib. All along the midline, as you go down, you can see this depressed area. This is the epigastric fossa, and deep to this epigastric fossa we have the xiphoid process. Okay, on either sides of the xiphoid process is the attachment of the seventh costal cartilage and forms the subcostal margin. And the importance of the sternal angle is here, that you can count the second rib, you can identify the second rib and start counting the ribs from further below, because you can have always supernumerary ribs. Okay, and we need this to identify muscle, count their digitations and extent of all the muscles. Okay, then more laterally if you go, so this is the infraclavicular fossa, or also known as the deltopectoral fossa, and this is the supraclavicular fossa. Sorry, this is the posterior triangle, and another small area here will be the supraclavicular fossa. And here you can appreciate this raised folded border that you can see over the skin forms the anterior axillary fold, and this is the axilla. So all along the clavicle, this will be the midline from the.
This is an excellent picture because they can't see the cadaver.
Yes.
And this is absolutely an excellent picture. So just point out first the infraclavicular fossa. Just not to confuse them, infraclavicular fossa is between the clavicular fibers of the pectoralis major muscle and the anterior fibers of the deltoid. And then it leads into the deltopectoral groove. Yeah, that's right. Go back please. Yeah, it leads into the deltopectoral groove. Very clearly it's visible here. And then the rounded contour of the shoulder formed by the deltoid muscle. Just outline that. Yeah, the whole muscle is visible. Yes. Yeah, that's right. So this is the deltoid muscle and the anterior axillary fold. Yeah, very good. Now this is formed by the pectoralis major muscle. Right? So very clearly it is seen. And the armpit behind this, just point that out. This is the axilla. Right? And as far as the skeletal landmarks are concerned, the medial end of the clavicle, just pointed out to them, both clavicles, the medial ends, yes, correct, and the other one, and between them, this little depression, the jugular notch or the suprasternal notch. And the sternum, the bone is represented by this furrow in the middle, in the median plane. Yeah, because its anterior surface gives attachment to the pectoralis major muscles on both sides. That's why, only this part. And then the xiphoid process is at its lower end. Xiphoid process. Yeah. So this is known as the epigastric fossa, the depression which overlies the xiphoid process. because they are going to be doing now pectoralis major. So this picture actually shows them the clavicular fibers can be seen, the sternal fibers can be seen. So clavicular, sternal, and then those which are rising from the abdominal wall. Yes, the external oblique. Yes. And then how the fibers are twisting around and creating this very well defined muscular ridge. So these are what you can call as the lateral or lower fibers of the pectoralis major muscle, because some fibers are actually twisting from anterior to posterior. This raises this very well defined anterior axillary fold. Excellent. Please proceed.
Yes, ma'am. Thank you, ma'am. And also appreciate that all these muscles are being seen or well defined when the hand is abducted, and there must be resistance against the abduction. That's why all these muscles are also visible. Okay, unlike the this side. Now another important landmark is the location of the nipple and areolar complex, and this usually lies along the fourth intercostal space, which lies between the fourth rib above and the fifth rib below, and along the mid clavicular line. The mid clavicular line is a vertical line which is drawn from the midpoint of the clavicle. That means from between the medial end and the lateral end, the midpoint, and you draw line down. That is known as the mid clavicular line, and the nipple areolar complex usually lies, it is not fixed, because this area, the pectoral region, can lodges the mammary gland, which is well developed in females and rudimentary in males and nulliparous women. So the position of the nipple varies, but usually it is confined to the fourth intercostal space medial to the mid clavicular line. Okay. So we keep this as a landmark and then further go into the dissection. So the skin over the pectoral region is supplied by cutaneous nerves, and these nerves are arising from the segments of the spinal cord corresponding to the thoracic second level onwards. Okay, and we are confined up till the seventh rib, so up till the T5, T6, T7. Okay, then more laterally over the clavicle, the skin over the clavicle and the deltoid are supplied by the cutaneous branches from the cervical plexus, and more down as we go into the arm, the cutaneous branches are coming from further segments of C5 and C6, which are taking part in the formation of the brachial plexus, which we will be doing in a subsequent class. Okay, and how the cutaneous nerves are coming out. Okay, so for that you would have to see the course of a typical spinal nerve. Okay, so from the intervertebral foramen, prior to that, within the vertebral column canal, from the ventral horn, dorsal horn. This is just a quick revision. So we have a ventral root, which is the motor root, and a dorsal sensory root. The sensory root can be identified by the dorsal root ganglion. The two of them unite to form the trunk of the spinal nerve, and through the intervertebral foramina the nerve exits and immediately divides into, now this is a trunk and the branches are known as rami. Okay, so the ventral rami and a dorsal rami. The dorsal rami carries usually the motor and the sensory fibers and divides. The dorsal rami go to supply the skin on the dorsum, and these nerves usually exit around 5 centimeters lateral to the spines in the midline. We can see them exiting from deep, so they will be piercing the structures deep to become superficial and then supply the skin. Similarly, the ventral root, the ventral ramus continues in the intercostal space, and along the mid axillary line it gives out this cutaneous branch, that is the lateral cutaneous branch. The lateral cutaneous branch then divides anteriorly and posteriorly to supply the skin over the lateral aspect of the thorax, and then the Spinal nerve continues giving out muscular branches all along, and at the lateral edges of the sternum the nerve exits as the anterior cutaneous nerve, which divides into a medial and lateral branches, and these branches supply the skin all along the chest wall. So, up till the mid clavicular line we have the branches supplied by the medial and lateral branches of the anterior cutaneous, and beyond the mid clavicular line we have the skin supplied by the anterior cutaneous branches of the lateral cutaneous nerve branches of the spinal nerve. Okay. So, this should be remembered, because if there is any clinical condition here, if there is any loss of sensation to that in that particular region, it can be traced back to the spinal segment of the spinal cord. Okay. That is the clinical implication. Okay, after we have seen the dermatomal distribution, this is your first picture of the cadaver, sorry, the second. Okay. So, along the bony landmarks, that is from the suprasternal notch, we have palpated it up to the sternal angle, then gone up to the xiphoid process, then laterally we have given extensions along the clavicle up till the acromion process, then to indicate the fourth intercostal space roughly, we have left the nipple areola complex on the skin, and then extend the incision more laterally along the anterior axillary fold up till the mid axillary line. Then below we have from the xiphoid process we have given a horizontal incision in the skin. Okay. Then in the skin here you can appreciate in the nipple areola complex, the nipple and the areola is the pigmented skin. The areola has modified sweat glands and sebaceous glands, and has hair follicles in the rudimentary breasts or underdeveloped breasts, but in the female breasts the nipple areola complex is well defined. Once we reflect the skin laterally, then we expose the tissue under the skin, that is the subcutaneous tissue or the hypodermis or the superficial fascia, which is loose areola connective tissue filled with lot of fat as a protection and packing material, and also as a passage for the deeper structures, arteries and veins and nerves to traverse and supply the skin. Okay. Once in the pectoral region within the superficial fascia, there are two important structures that we will see. One structure has not been dissected out, that is the platysma. The platysma is a subcutaneous skeletal muscle arising from the pectoral fascia, which is the deep fascia further below. Then this up till the lateral aspect of the pectoral region, the muscle travels upwards and to get inserted along the base of the mandible. Okay, I have a picture, I will show you, but just to mention the structures here. Then the rest within the superficial fascia of the pectoral region, we can appreciate the increased amount of the adipose tissue in the mammary gland. The mammary gland is nothing but the modified sweat gland present in the pectoral region, and under deep to the superficial fascia. Oh yeah, this is the picture I tried to put for you to depict the thin sheet of subcutaneous muscle, that is the platysma. The fibers are directed upwards and medially to get inserted into the base of the or the margins of the mandible inferior. It is a skeletal muscle supplied by the facial nerve, motor branches of the facial nerve, and functions, it helps to maintain the contour of the skin and move the skin over the clavicle and in the neck freely. So, going to the next slide. After we have reflected the superficial fascia is also incised as per the skin incisions. Then along the lateral border of the sternum, here along the lateral border 2 to 3 centimeters lateral border of the sternum, you can appreciate the intercostal nerves that are piercing to come out to become cutaneous. Once the superficial fascia is reflected, what we see is the muscle covered by the deep fascia. The deep fascia in the pectoral region is known as the pectoral fascia. The pectoral fascia, we will see their attachments. So the pectoral fascia covers the pectoralis major muscle. Medially it blends with the periosteum of the sternum. Superiorly it blends with the periosteum of the clavicle to go beyond into the neck to become continuous with the fascia in the neck. Then more laterally it continues into the axilla as the axillary fascia, and it covers the back muscles and continues with the fascia in the back. Okay. Then deep to the deep fascia we have the muscle, that is the pectoralis major muscle. This tough sheet that is adherent to the muscle fibers is the pectoral fascia. You can appreciate the direction of muscle fibers in skeletal muscles. The direction of muscle fibers is very important, which will help you in understanding the actions. So we see this is the major muscle in the pectoral region, that is the pectoralis major. We'll come to its attachment. The yellow here is all the fat. Okay, the fat retains most of the preservative fluid and becomes this color. So here the pointer is showing the attachments of the pectoral fascia with the muscles to enclose it. After incising the pectoralis major from its attachments deep to the pectoralis major muscle, deep to the pectoralis major muscle we have another muscle, that is the pectoralis minor. We will see its attachments and then the nerves that are supplying the pectoralis minor. In this plane, as we go close to the clavicle, between the first rib and the clavicle, we can even appreciate the subclavius muscle. Okay, so now coming, we have seen the platysma. Then the other structure is the mammary gland and the nipple areolar complex and the cutaneous nerves. So the cutaneous nerves here we have seen are the anterior cutaneous nerves of the 2nd to the 7th intercostal nerve segments within the pectoral region. One important point of observation is along the sternal angle there is this region of discontinuous dermatomes. Okay, as the T1 spinal nerve has no cutaneous innervation anteriorly, it has only posteriorly. So this line is known as the demarcation between the cutaneous innervation of the neck and the thorax. Elsewhere in the body it's usually on the dorsum, it is continuous. Okay, and why C5, C6 and all are not being seen here is because the appendages are an extension, lateral extension from here, so they drag their nerve supply along with them into the upper limbs. So the same thing. Yeah, coming to the pectoral fascia, you can appreciate this is the region of the pectoral fascia covering over the deltoid, going up, blending with the periosteum of the clavicle, going up into the neck as the cervical fascia. Then into the axilla it extends as the axillary fascia and covers the muscles of the back. Into the arm it continues as the brachial fascia. So like we discussed, the deep fascia is roughly continuous, all are trying to enclose all the muscles and the bones and the neurovascular structures in relation to them. Okay, deep to the pectoral fascia. So this is the axillary fascia just. So deep to the pectoralis major, deep to the pectoral fascia is the muscle pectoralis major, and deep to the pectoralis major is the muscle pectoralis minor. Okay, the pectoralis minor is covered by the fascia, that fascia, and as the pectoralis minor extends close to the clavicle along with the subclavius. So this fascia extending from the clavicle into the pectoral region is known as the clavipectoral fascia. Okay, so the other fascia that we see in the pectoral region is the clavipectoral fascia. So we'll see the extent of the clavipectoral fascia. Okay, so the clavipectoral fascia lies deep to the pectoral fascia, covering the pectoralis major muscle. This is the pectoralis major muscle. Sorry, I couldn't label it. So this is the pectoralis, this is the clavipectoral fascia. Deep to the pectoralis major, this is the pectoralis minor muscle, whose attachments we'll see, but we've covered the subclavian muscle, subclavius muscle, which is lying in the subclavian groove below the clavicle. So this fascia is known as the clavipectoral fascia. Okay, so the clavipectoral fascia is attached to the margins of the subclavian groove, then encloses the muscle along the lower border of the subclavius muscle. It unites into a single layer, and as it, so somewhere here is the subclavius. So below this is the single layer, that is the clavipectoral fascia. Once it comes to the upper margin of the pectoralis minor, it splits to enclose the pectoralis minor, and the next structure it meets is the axilla. So this fascia extends into the axilla to form the suspensory ligament of the axilla. Okay, so again I am saying the clavipectoral fascia is a deep fascia lying deep to the pectoralis major and the pectoral fascia. It is a fascia that encloses the second layer of muscles, that is the subclavius and the pectoralis minor. So excuse me, it encloses the subclavius, forms a layer, that is the clavipectoral fascia, then splits to enclose the pectoralis minor and extends into the axilla as the suspensory ligament of the axilla, which holds the pectoral fascia continuing as the axillary fascia. Okay, so when you extend your arm, the axillary pit is very prominent and becomes arched. Okay, that arching is because of this ligament or attachment of the fascia. So hence this fascia, this clavipectoral fascia in this region is named as the suspensory ligament of the clavicle. Okay, so we have seen in this plane more laterally we have seen. Superiorly beyond the clavicle, this clavipectoral fascia merges with the clavicle. Then more medially beyond the clavicle, it continues as the fascia around the axillary vessels as the axillary fascia. Okay, so this is with the clavipectoral fascia. It's a very important structure because there are structures that are trying to become superficial or deep, and hence the structures that are piercing this clavipectoral fascia are very important. So in this picture you can appreciate this is the vein. Okay, so the continuation here. So if this was the first strip, the structure beyond the first strip will be the, this will be the axillary vein. Okay, so this is the axillary vein, and then we have a superficial vein which is the cephalic vein. Okay, this cephalic vein is a vein that is beginning from the radial side of the thumb. So where arteries end as capillaries, from there venules and lymphatics begin. So the venules, the veins unite on from the radial side of the upper limb as the cephalic vein, and they travel, and this, because it is superficial, it has to drain into the right atrium. So for that the cephalic vein opens or acts as a tributary of the axillary vein. So here in the, this is the structure to show, this is, in this you can see the structures that are trying to pierce and go from a different plane superficially or deep. So coming to structures that pierce the clavipectoral fascia. So as we said, the clavipectoral fascia covers the pectoralis minor and subclavius, which are lying beneath the pectoralis major. Okay, so between the pectoralis major and the deltoid muscle, we also have the deltopectoral groove. This deltopectoral groove lodges the cephalic vein and few lymphatics which have to enter into the deep lymph nodes in the neck. Okay, so till here the cephalic vein is superficial, Once in this deltopectoral groove, deep to the deltopectoral groove, we have the clavipectoral fascia. So the cephalic vein pierces the clavipectoral fascia to drain into the axillary vein. So one structure that is piercing the clavipectoral fascia is the cephalic vein. The other structures are the muscles that supply the pectoral region. One is the lateral pectoral nerve. Okay. So the lateral pectoral nerve is coming from deeper plane from the brachial plexus, piercing the clavipectoral fascia to supply the pectoralis major and minor muscles. Okay. And from the deeper plane to give cutaneous supply to the skin and also to enter into the arm, we have a smaller branch from the axillary artery, the thoracoacromial artery, and accompanied by the veins. So artery and veins together we call them as vessels. So thoracoacromial vessels. Along with this, lymphatics which have to drain into the deep cervical lymph nodes, that is the infraclavicular group of lymph nodes. So these lymphatics are also accompanying these blood vessels. Okay. So finally, to summarize, the structures that pierce the clavipectoral fascia are, okay, a lateral pectoral nerve, cephalic vein, few lymphatics, and the thoracoacromial artery, which is not depicted here. And you can appreciate these globular structures are the lymph nodes in the axilla. So pectoralis major, it is a powerful fan shaped muscle. It has a broad origin. The origin is as three separate parts. The clavicular part, which we have seen already, is the attachment along the has its attachment along the medial 2/3 of the anterior surface of the clavicle. Then we have the attachment along the sternum at the junction of the costochondral cartilages with the sternum anteriorly. That will be the sternocostal end, and the lowermost fibers which are arising or taking attachment from this flattened sheet, that is the aponeurosis of a flat muscle, that is the external oblique abdominis muscle. Okay, so these fibers are known as the aponeurotic or abdominal fibers, which are the lowest. So as per their directions, you can see the clavicular fibers are slightly oblique, running downwards and laterally and superficially to they are going laterally. Okay, whereas the clavicular sternocostal fibers are usually horizontal, and they go in a deeper plane to the clavicular fibers laterally, whereas the abdominal fibers are traveling upwards and laterally, and they go in a more deeper plane. Okay, as it has a broad origin and a very narrow insertion, the muscle folds upon itself, and hence found here the abdominal and the lowermost sternocostal fibers form the rounded twisted border that forms the anterior axillary fold. Finally, all these muscles, finally all the fibers together go for their insertion into the humerus. Okay. So the humerus is a long bone. It has an upper end. In the upper end, the presenting parts are majority is the major part is the head of the humerus, and more anteriorly we have a lesser tubercle and more laterally a greater tubercle. Okay. Between the two tubercles we have a longitudinal depression, which we call it as a groove. Okay. So between the two tubercles it's a groove. So we groove or a sulcus. We call it as a bicipital groove or intertubercular sulcus. So as this as a sulcus or as a groove, it has two raised margins. The one closer to the midline, closer to the head, is the medial lip, and another is the lateral lip. So the pectoralis major insertion is very unique and important, that the three parts are arranged in three different lamina, twist around them such that the clavicular fibers are superficial and go most inferior for their attachment along the lateral lip of the intertubercular sulcus, whereas the sternocostal fibers are oblique or horizontally running, and they form the intermediate layer and attach to the intermediate part of the intertubercular sulcus, whereas the abdominal fibers are running upwards and get inserted into the highest point of the tendon along the intertubercular sulcus. Okay. So, this forms an inverted, not inverted, it forms a U which has two unequal limbs. So, that is the twisted insertion of the pectoralis major muscle. Okay. So, coming to the actions. Yeah. So, if the clavicular fibers contract, they are going to pull the humerus more forwards and to the midline. So, that kind of action is known as flexion. If the sternoclavicular fibers which are horizontal contract, they tend to pull the humerus towards the midline adduction, and as these fibers are twisted, some amount of medial rotation occurs at the shoulder joint. When the upper limb is extended, like overhead abduction and extension, this action untwists the tendon, untwists the tendons and makes them all parallel, and this action, this is useful in apes who are like arboreal, hanging from trees, and helps even in us when we use this part of the muscle along with its posterior counterparts like the latissimus dorsi as a climbing motion. So, this pectoralis major also can be described as a climbing muscle. During this climbing action, the upper limb is fixed, or the humerus is fixed at the shoulder joint, whereas the clavicular, sternocostal and the abdominal attachments is active and it contracts, hence pulling the axial skeleton or the thorax upwards and slight amount of forwards. So, like that's the action when you do your pull-ups. Okay, when you do pull-ups, you are going up, also going towards something forward. Okay, so that is the climbing action of the pectoralis major along with its posterior counterparts. The nerve supply of the pectoralis major is by the medial and lateral pectoral nerves, which are branches from the brachial plexus. Okay, then the blood supply is from the axillary artery branches. Okay, then coming to the relations, the pectoralis major superiorly is related in the superficial fascia structure to the mammary gland. Hence, the pectoralis major forms 3/4 of the mammary bed and shares this along with the abdominis, external oblique abdominis muscle inferiorly. So, major relation anteriorly to the pectoralis major is the mammary gland and the pectoral fascia anteriorly, and more posteriorly behind the pectoralis major relations we have is the pectoralis minor muscle covered by the clavipectoral fascia and the structures that are piercing, right, and more medially we have the intercostal muscles and their membranes. We will see what they are. So, with this we finish the pectoralis major muscle. Any doubts here? Okay. Coming to the pectoralis. Insertion, yes. See, this is a big muscle which it is a powerful muscle which has a wide origin or wide proximal attachment, and the distal attachment or insertion is very narrow. Okay. So, the fibers have to rearrange themselves to get accommodated. So, that rearrangement is such that the uppermost fibers will be superficial. Is my audio clear?
Echo for a while.
Yeah, for a
Do you
while.
want to take a break? I'll because you're looking very fatigued.
No, no, ma'am.
Can
Like,
I
I'm just
explain?
nervous. I want to finish it.
Just have a drink.
No.
I'll just explain this.
Gigi, yes, ma'am.
Okay.
Please. Thank you. Thank you,
So
ma'am.
the insertion of the pectoralis major muscle, you have to take into account the fibers that are coming from different parts of the rib cage and clavicle and the orientation of those fibers. The uppermost fibers are the clavicular fibers and the direction is downwards and laterally. Then you have sternocostal fibers arising from the anterior surface of the sternum and from the upper 6 costal cartilages. And then there are abdominal fibers which arise from the superficial surface of the external oblique aponeurosis. Right? The sternocostal fibers can be described in two parts. The upper part, the upper sternocostal fibers, which pass more or less transversely, and the lower sternocostal fibers, which pass upwards and laterally. And you have the abdominal fibers from the external oblique aponeurosis also going in a similar direction. Fine. Now at the insertion, the pectoralis major muscle, the lowest fibers, that is the abdominal fibers, they come to lie. Is there an echo? There is an echo. Okay. All of you please just mute your mics, and Dr. Harisha, you too. Just mute the mic, then the echo will not happen. So okay. So the insertion of the pectoralis major muscle is described as in the form of a bilaminar. Some people like to describe it as a trilaminar tendon. The complete insertion is on the crest of the greater tubercle of the humerus, also known as the lateral lip of the bicipital groove. The bicipital groove is so called because it lodges the log head of the biceps. This groove, because it lies between the greater and the lesser tubercle, is also known as the intertubercular sulcus. Okay? Now, the clavicular head of the pectoralis major muscle are the most superficial fibers. They constitute the most superficial fibers. And then on a slightly deeper plane laterally, we have the upper sternocostal fibers which are passing transversely. Okay, so there is a U-shaped insertion. The lower sternocostal fibers form the base of the U. Fine, clear? The base of the U is formed by the lower sternocostal fibers. The abdominal fibers form the upper part of the posterior prong of the U. Remember, the U is in a sagittal or parasagittal plane. The U is in an oblique, slightly oblique parasagittal plane. It's the front, there is a layer in front and there is a layer behind, and there is the bottom or the base of the U. Right? So the posterior lamina or layer of the U is formed is from below upwards by the lower sternocostal fibers and the abdominal fibers. The base of the U is formed by the the base of the U is formed by the lower sternocostal fibers, and the anterior layer is formed by partly the upper sternocostal fibers, and if you describe it as a trilaminar tendon, most superficially overlapped by the clavicular fibers. So from anterior to posterior, clavicular fibers in front, then the upper sternocostal fibers, then the base of the U by the lower sternocostal fibers, and the posterior layer of the U, the posterior prong is formed by the abdominal fibers. So that's how it's a bilaminar, or some people like to call it trilaminar tendon of insertion. And because there is a twisting happening at the level of the lower sternocostal fibers, because of that there is a very prominent muscular ridge created inferolaterally, which we recognize as the anterior axillary fold, that is palpable. The U is not inverted, no. The U is front to back. The U is not in a coronal plane. Does that make sense? The bottom of the U formed by the lower sternocostal fibers, the anterior layer by the upper sternocostal and clavicular fibers, posterior layer, the posterior prong of the U by the abdominal fibers, or the posterior lamina. I'm just giving a term, prong. This is not a technical term. So you can describe this tendon of insertion as having two layers or laminae, an anterior layer and a posterior layer. The word lamina also means layer. So an anterior lamina and a posterior lamina. The anterior lamina can be considered in further two layers if you describe it as a trilaminar tendon. But if you keep it to a simple explanation, bilaminar tendon, the anterior layer or lamina consists of the upper sternocostal fibers and the clavicular fibers. The base of the U consists of the lower sternocostal fibers, and the posterior lamina consists of the abdominal fibers. The inferolateral border of the pectoralis major muscle becomes prominent when you flex against resistance. No, I'm sorry. The clavicular fibers become prominent when you flex against resistance. The sternocostal and abdominal fibers become prominent when you extend against resistance. And then you can feel this bulging. You know, bodybuilders like to show off their pectoral muscles. So that bulging, oblique, prominent border that is formed inferolaterally, that's your anterior axillary fold. Please continue, Dr. Harishna.
Yes, ma'am. Yes, ma'am. Oh, again my screen is frozen.
This conference is no longer being recorded.
Okay. Now can we move to the pectoralis minor? So on a deeper plane, after reflecting the pectoralis major, we come across another muscle in the pectoral region, that is the pectoralis minor. So the pectoralis minor takes its origin from the outer surface of the third, fourth and fifth ribs at the junction between the costal cartilage and the ribs. Okay. So it does not encroach upon to the costal cartilage, unlike the pectoralis major muscle. Okay. That is the difference you should appreciate. So it takes its origin from the outer surface of the third, fourth and fifth ribs, and then the muscle fibers are directed laterally and superiorly, and then the muscle forms a tendon to get inserted into the medial and the superior aspect of the coracoid process. Okay. So this is the pectoralis minor muscle. The nerve supply, it is supplied by the lateral pectoral and medial pectoral nerves, and the blood vessels are the same branches from the surrounding axillary artery branches. Coming to its action, as it is going from the midline laterally and from anterior posteriorly, on its contraction it tries to pull the coracoid process downwards and forwards, so that the scapula swings around the lateral surface of the ribs. Okay, this kind of action is seen like when you are punching. So this action is known as protraction. So the main actions of the pectoralis minor are slight depression of the scapula and protraction of the scapula. Okay. Yeah, like this pectoralis major, the pectoralis minor, as they are attached to the ribs, they help in forced inspiration. Then the other muscle is the subclavius. The subclavius also takes its origin from the junction of the first costal cartilage and the first rib. Then the muscle, the direction of the fibers are more laterally and then gets inserted into the middle 1/3 of the inferior surface of the clavicle within the subclavian groove. Okay, and both these muscles are enclosed by the fascia. What is that fascia?
Clavicopectoral fascia.
Very good, very good. Clavipectoral fascia. Structures piercing clavipectoral fascia. Ma'am, my screen is getting stuck, frozen very often, ma'am.
Never mind, you're almost
Finished.
It's okay.
Yeah, no, sorry. Coming to the action of the subclavius muscle, yeah, we've seen its attachments. The subclavius muscle is the nerve supply is from the brachial plexus, a nerve that arises directly from the, we'll see in the brachial plexus at the upper trunk. So that nerve has no specific name, but it's called the nerve to the subclavius muscle. Unlike the lateral or medial pectoral nerves, this nerve is just called as the nerve to the subclavius. Okay, and depending upon its location and the fibers, we can say that the subclavius has an important role in steadying the middle of the shaft of the clavicle during scapular rotation and axial rotation of the clavicle at the sternoclavicular joint. So basically it steadies the clavicle, or by decreasing the distance between the clavicle and the first rib, one thing, and also keeps the clavicle fixed when it is in axial rotation during the scapular rotation, movements at the shoulder joint. Okay. Beyond this, then we have the blood vessels that are present in the pectoral region. For that I need to show you. Okay, so deep to the sternum we have the heart. From the heart we have the main trunk that is arising is the aorta. Okay, the aorta gives out 3 branches. One branch on the right known as the brachiocephalic trunk, and on the left we have 2 branches, a medial branch going directly cranial, that is the common carotid artery, and a more lateral artery destined for the left upper limb known as the left subclavian artery. Okay, so now the brachiocephalic trunk at the level of the first intercostal space, it divides into 2, an artery that has to go supply the head and neck and the brain, that is the common carotid, that is the right common carotid, and the right subclavian. So the right subclavian is the artery that is destined to feed the upper limb. So this subclavian artery, after its origin with its course in relation to the first rib, beyond the first rib the subclavian artery continues into the axilla as the axillary artery. So, the pectoralis minor muscle is the key muscle in the pectoral region, as it divides the axillary artery into three. So, the artery that lies proximal to the pectoralis minor is known as the first part, the artery that lies behind the pectoralis minor is the second, and the artery that lies beyond or distal to the lower border of the pectoralis minor is known as the third branch. Okay. So, the blood supply to the pectoral region is from all these arteries that surrounding it. Okay. So, from the subclavian trunk, the left subclavian artery and the axillary artery. Okay. So, from the subclavian artery, the mnemonic we use, because I am in a hurry, I just want to, and my screen I am not able to share. The mnemonic to remember the branches of the subclavian artery are vitamin C and D. V, I, T, C and D. Okay. So, V stands for vertebral artery, which is destined, it has to go to the.
Dr. Varisha, you don't have to do the branches of subclavian artery in pectoral region.
No ma'am, I want to tell them about intercostal, interthoracic, intermammary.
That may be so, but that will be too much.
Ma'am, I have a picture to show them, but my screen, I am not able to go to the next slide.
Yeah, but don't.
Okay, okay ma'am. So,
the pectoral muscles and the clavipectoral
fascia.
Okay.
Yes ma'am.
There will be other opportunities.
Am I audible?
Yes, you are audible.
Okay. So, along the intercostal spaces, we have intercostal arteries. Then intercostal arteries are namely, if they are in the anterior aspect of the thorax, we have anterior intercostal arteries. If they are running along the posterior part of the ribs, they are posterior intercostal arteries. So, these intercostal arteries, anastomose and their perforating branches supply the muscles and the structures in the pectoral region, and especially in the region of the mammary gland, these arteries are well developed. Another artery in the along the lateral border of the sternum is the internal thoracic artery, which is a branch from the subclavian trunk, subclavian artery. This internal thoracic artery gives out these anterior intercostal arteries. Okay. So, as the mammary gland lies over the second to the sixth ribs, the intercostal arteries along these intercostal spaces are very well developed and are also known as mammary arteries, lateral mammary arteries. Okay. Then the other branches are mostly from the axilla, which are coming to supply, are mostly the thoracoacromial artery, which we saw. It also pierces the clavipectoral fascia. So, as after piercing the clavipectoral fascia, it gives out 4 branches: clavicular branch, acromial branch, then a deltoid branch and a pectoral branch. These branches give the vascular supply to the structures in the upper aspect of the thorax, of the pectoral region, sorry. Then along the lateral aspects, we have the lateral thoracic artery also supplying the pectoral region, and the corresponding veins are joined. They drain into the axillary vein. Axillary vein continues as the subclavian vein. Subclavian vein again unites with the internal jugular, forms the brachiocephalic. Right and left unite to form superior vena cava. Then what could be the applied anatomy here is when there is spasm or any lesion, usually spasm of the subclavius muscle or the pectoralis minor muscle, with so the muscles are in constant contraction, and the axillary artery and the subclavian vessels that are related to these two structures respectively, they can get compressed, and then you will have neurovascular deficits in the upper limb. Yeah, you will have to memorize. Okay. So, and when there is neurovascular deficit, you'll have altered sensations, paresthesia over the skin, then loss of blood supply, tingling sensation, loss of pulse, feeble pulse, etc. Okay. So, these are mostly the applied aspects I wanted to show you some dissection prosected specimen things. But anyways, this PPT and the videos that I wanted to share with you, I will upload them into the Saral platform today evening itself. Okay, so your post class task will be to read the clavicle, try to understand just by description whether you can visualize and study the clavicle. Okay, and at least from now you should start you should be able to
Just show them.
tell.
Just show them the video, just so that they have a visual reference.
That's what, ma'am, my screen is totally frozen. I'm not able to go to the next slide. Nothing. If I have to.
You're not able to show them.
Nothing, ma'am. I have
Okay,
to.
then we'll keep that for the next time.
That's what, ma'am. I have to exit and again join the meeting again.
Because it is difficult uploading those videos because their size is very big.
Acha, okay, ma'am.
That's why I always prefer that they are shown during the class. It is difficult to upload.
I have it in my mobile.
You can just show them.
I have it in my mobile, ma'am. Can I?
Not working. It's not working.
No,
Okay,
the screen is totally frozen, ma'am. Ha, ma'am.
I have to share the video.
Yes, ma'am. Yeah, I can do that, ma'am. Can I upload them in the WhatsApp group, ma'am?
Yeah, absolutely. That is possible. Yeah,
okay.
That's a great suggestion.
Yes, ma'am.
Just show them in the WhatsApp.
Yes, ma'am. I'll do that.
There it goes very.
Acha, I can do it now itself, right? So that they can open on their own. These videos are muted, okay? So the intention was that we would describe them as the video is going on. So the task would be you should try to identify the structures as the video is going on, okay? Any doubts, you can pause the video and ask questions, take a screenshot, what is this and all that. They're taking time to load. Other than this, any other doubts from the class? All these skeletal muscles, you should be thorough with their origins, insertions, nerve supply and actions. Okay, so you can start taking tasks of studying one muscle daily. I totally agree. I should not have extended the class so long.
I think we'll have to give pectoral region another session. We'll probably have to play the AIIMS videos as well.
Okay, ma'am.
For pectoral region. And also the videos you have made. You made on clavicle, right?
And the dissection also, ma'am.
And the dissection. So clavicle is okay. I would ask you to play the dissection video if possible. So that most of their doubts will get clarified.
But how can I play, ma'am?
You have put them on the WhatsApp group?
Yes, ma'am.
Okay. Now, if you make me the presenter, I can play the video for them.
Okay, ma'am.
Which number is it? 538 to the last one, huh? The first three are clavicle, I think. No, all are clavicle.
No, ma'am.
Ones which you have mailed.
There's a second mail. 140 mail.
stop now. They are also fatigued.
They are typing that beyond 2 hours it's difficult
I
for
only
them.
have the clavicle drop videos. I don't have the others.
Okay, ma'am.
I think we can stop now. If they want, somebody had a question about can we see, can we feel the U? I could demonstrate that somewhat. Yeah, this is a good picture. It's very good. It shows the pectoralis major reflected to expose the pectoralis minor muscle.
Okay.
And the left side image shows the pectoralis major. The clavicular fibers have been cut in a window fashion to show how
Yes, ma'am.
the lateral pectoral nerve is supplying the
Yes, ma'am.
pectoralis major muscle.
Yes, ma'am. Minor, major.
The minor pierces, the medial pectoral nerve pierces the minor and then supplies the major.
Yes, ma'am.
But the lateral pectoral nerve usually comes in the gap between the subclavius and the pectoralis minor muscle and supplies the pectoralis major muscle from its deep surface.
Yes, ma'am.
From its deep surface. Yes. I think they're leaving now. We'll stop here. Close the recording. Dr. Harisha, just close the recording.
Yes, ma'am. Yes, ma'am. I had stopped it.
Okay, you stopped it. Fine. So, Dr. Renu wanted to try out once. So, can you make, I'll just call her, can you make her the presenter because she has major issues, so she wants to take her lectures from home. So, can you just make her the presenter once?
How should I do that, ma'am?
She'll have to join it. So, let me just call her up. So she's speaking to someone else. It's okay. We'll stop here.
Ma'am, now the slides are showing.
The PT attendant hasn't come so far?
No, ma'am.
Oh, she's... hello, Dr. Renu. Can you join the GoToMeeting? Dr. Harisha is there. 1 minute. Join her. Hello? ठीक. She'll just join the meeting.
Ma'am, how to make ma'am the presenter? Mouse. Where is the list? Meet the presenter. Okay.
Were you able to do it?
Ma'am. Yes, ma'am.
Can you see, Arishma, can you see my screen?
Yes, ma'am. How does the sperm get through the barrier surrounding the egg?
Yes, we can see your screen. Dr. Renu, we can see your screen.
Yes, ma'am.
So then it's okay.
Yes, ma'am. Your audio is also very good.
ठीक है. एक सेकेंड.
बहुत क्लियर है.
आगे नहीं जा रहा मेरा स्क्रीन. हाँ, ठीक है. It's changing, ना?
Yes, ma'am. It's changing.
Okay.
तो सारी चीजें हो रही हैं. The LT attendant has left.
अच्छा,
The
yes,
LT attendant has left. मनमोहन has left. वो अपना फोन स्विच ऑफ करके भाग गया.
ठीक है.
So this is
I
just
think
a trial
you
run.
can hear me also, Harisha.
Yes, ma'am. I can hear you, ma'am. How are you, ma'am?
And screen is full.
No, ma'am.
You can see full screen or it's a small screen.
No, it's not small.
या फिर तो आप तो GoToMeetings पे हो गए ना?
full screen.
हाँ मैं go to meeting पे हूँ.
Or Harisha, you?
Yes, ma'am. Ma'am, I'm also on go to meeting.
She's in LT2.
LT2.
No, but she's in the LT2. She's in LT2. I can see the full screen. I can see the full screen, Dr. Renu, बिल्कुल perfectly.
Then it should not be a problem. ठीक है.
No, I don't think so.
ठीक है. Okay. Thank you so much.
Thank you, ma'am.
So it can be done, right?
ठीक. हाँ. Thank you, Harisha.
Thank you, ma'am.
Now you can close the meeting. She's really exhausted.
No.
Please close the meeting.
Thank you, ma'am.
Right.
She can close the meeting now. 3 hours is little too long.
Yes,
Too
ma'am.
long. But they have so many doubts now what to do. They are not able to see the structures. क्या करूं?
What was the topic?
Pectoral region clavicle.
Okay. Oh, both.
First time. Yeah, both.
It was 2 hours, ma'am. I extended it to 3. हाँ, can be done. जी.
Because you did clavicle for nearly 2 hours, Harisha. There
Yes.
was no need.
Yes,
You
ma'am.
should have finished it maximum by 1.5 hours.
Okay, yes,
You
ma'am.
took 2 hours nearly for clavicle.
Yes, ma'am.
Okay. Anyway, it was well done.
जी जी
It was well done.
जी. Thank you.
Chalo, close the meeting. Close the meeting.
Thank you, ma'am. I'll do that. I'll end it. Ma'am, how did you go to this chat option? Because the whole screen is full of my my PPT
Yeah,
only.
exactly. कल पता है मेरे साथ भी यही हो रहा था. There was this minimize and maximize
I could not
वाला
even
thing
see
ना.
how many children are there.
Okay. वो एक ना वो full screen इसका वो आता है option.
Hello, ma'am. हाँ, ma'am. I was asking whether again should I end because there were few students also. Yes, yes, ma'am. No, no, no. मैम को बनाया था जी 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 हाँ आई ऑल्सो डिडंट नो विदु मैम केम एंड हेल्प्ड मी मैम वी हैव दैट कॉन्टैक्ट्स नो मैम हाउ मेनी स्टूडेंट्स आर देयर attendees in the attendees against the person you want to go you should click on the right button extreme then so many options will come out one option was make presenter जी हाँ हाँ okay ma'am okay ma'am then I will know the ID same ID ma'am ma'am same the academics the previous one what we were MBBS first year you try to join back हाँ हाँ जी 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 हाँ हाँ once you join the meeting and I'll tell you हाँ हाँ
She will not be able to start. Start will be from the academic section.
ma'am because
ये दोबारा क्यों आ रहे हैं? 11 ही है सिर्फ. Okay. So now
ma'am you are presenter
okay. So you made me the presenter.
yes because I started the
I'll
meeting
try to make you the presenter. Okay. I'll try to make you the presenter.
हाँ
So I have to go to the
attendees
okay, and then
scroll down to my name ma'am or academic whatever
I'll come down to
academic section
right?
names जी ma'am
Now
then
what do I do?
on your mouse click the right button.
Just a second.
जी मैम.
You are already there. Can you unmute yourself?
Yes ma'am.
And talk on the directly.
Yes ma'am. You can hear me ma'am? I'll cut the.
Yeah. Yeah, I've cut the phone.
I can hear you ma'am. You
Now
can
what
hear
do
me?
I do? Now you tell me what do I do?
Against the academic section AIIMS ma'am, when you take the cursor there, it gets little darker, gray. My academic section is highlighted now ma'am. There is a drop down.
The people, right?
हाँ people में academic section AIIMS.
Okay.
Next to my
section AIIMS.
Yes ma'am.
There is a mic.
हाँ, next to the mic there is a arrow, no ma'am? Inverted arrow.
There is an arrow.
हाँ ma'am, click on with your mouse. Click on the right. Give a right click on the mouse, ma'am.
Verify presenter.
Yes. Yes. Yes.
Now you are the.
Yes.
Now you are the presenter.
Yes, ma'am.
Can I do it once more? Can you
Yes.
make me the presenter again?
Okay, ma'am. I'll do that.
I'm so sorry.
Ji.
But I'm really not good at.
No, ma'am. Same. If I knew this, ma'am, I would not have such a bad class today.
You had a great class today, dear.
No.
The thing is, you went too long to the clavicle.
Ji.
But I suppose that was also necessary.
No, ma'am. It was. Ma'am, you are here.
Okay. So I've been made the presenter.
Ji, ma'am.
I can share my screen.
Yes, ma'am. I can.
And now to make the presenter, I'll just go to academic section and make you the presenter. Yes. Okay, done. That's great.
Ji, ma'am.
Fine. That's great.
I also learned something today.
We learn as we do. We
Yes,
all are
ma'am.
learners.
Yes, ma'am. Experiences.
Kids are very good with this technology. They
No.
are extremely good. And
They
we
know.
don't know.
Yes,
That's
yes.
what handicaps us. In the first lecture, I was so conscious of not knowing the technology that I was not able to speak in a flow at all.
Ji,
Not
ji.
my usual self at all.
Ji.
It's an unfamiliar milieu, isn't it?
Yes, ma'am.
So, chalo. Okay.
There are some 3 kids still in the class. Yes, ma'am. I'll end the meeting.
Yeah, please do.
Thank you, ma'am, for all your help.
Not at all.
Ji, ma'am.
You're most welcome.
Thank you, ma'am. If any children are there, this is the last. We will be ending the meeting.
Let it be just end the meeting.
Yes, ma'am.
They've all left. Except for few of them.
For them I was
Just
just.
send the.
Yes, ma'am. Ma'am, I can see you now. Hello? Just now finish. 5. 5 o'clock. I don't know if the room is open. I think I'll go have to pick up my stuff from DH and come. Hold on. Hello? Ma'am, I was just thinking nothing will happen now if we put the videos on WhatsApp again, they'll get circulated and cadaveric images. Nothing, no, ma'am? डाल दिया था ना मैम, तो डिलीट शायद नहीं होगा। हाँ 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 जी मैम, दैट्स व्हाट आई सेड, एटलीस्ट हल्का सा दिख रहा है मैम। नहीं, फोटोज अलग है मैम, बट वीडियो में एक जस्ट फॉर ओरिएंटेशन कि हम कहाँ से कहाँ जा रहे हैं, एक फेस से देन वी आर गोइंग डाउन। कहाँ मैम, सरल पे या? हाँ हाँ मैम, दैट्स व्हाट आई टोल्ड बिकॉज द मैम बिकॉज ऑफ द जॉइंट्स ना, आई थिंक इट वेंट लॉन्ग। सर आई नो मैम। कहाँ करेंगे मैम जॉइंट? बिकॉज एक्सप्लेन्ड। हाँ 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 ओके मैम। जी जी ओके 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 जी मैम। जी 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 ज़रूर। व्हाट अबाउट इमेजेस मैम? यस थैंक आई आई एम नॉट सेटिस्फाइड। जी जी यस मैम, आई विल डू दैट। यस मैम, थैंक यू मैम। व्हाट अबाउट द वीडियो मैम, आई कांट डिलीट नाउ। Ethical whatever issues. Hello ma'am. I just now saw it ma'am. Actually now for me the double tick didn't come. Maybe because I don't have good internet here. That is what I did ma'am. Just now I saw it was single tick, so I did it. I deleted. You just said no. हाँ मैम, or else I'll try to give voice over along with it, and then I'll make it in something and I can upload it for. हाँ हाँ सही में मैम। जी जी यस यस डेफिनेटली मैम। हाँ हाँ, BD84 हर बुक के साथ CD आता है मैम। नहीं वॉइस जी 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 ओके ओके हाँ करा सही में मैम स्पार्क नाउ जी जी schedule yes ma'am हाँ 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 कोविड जी मैम जी जी ओके आई एम लॉकिंग अप एंड कमिंग थैंक यू बाय